our fourth annual Pediatric Specialists of Virginia NPPA Education Day. We were hoping to, have this in person, but here we are. So we're just really glad so many of you could join us. My name is Neha Atali. I am one of the neurology nurse practitioners with PSV, and I've been here for about 6 years. We, first started this conference in 2018, basically as a way to highlight the advanced practice providers here at PSV and to kind of make ourselves known to the primary care community. There's many local providers who are familiar with a lot of our physician colleagues, but don't know a lot of us and the fact that, we are available as resources to your patients as well. As many of you know, Pediatric Specialists of Virginia is a joint venture between Children's National and Inova Health System. And we actually just celebrated our 8th anniversary as an organization, and we have continued to expand and add more specialties throughout the years. So for those of you who attended this in previous years, welcome back. And then for all of those who are new, we hope you continue to join us because we do plan to make this an annual event. You will be able to get 5 CMEs from today, and we'll kind of go over that at the end. But we do want to kind of go ahead and get started because we have 5 great speakers today, and we don't want to get ourselves too behind in the schedule. So basically, the speakers are going to be leaving some time at the end for questions. So if you could try to hold your questions till the end, unless they, specify otherwise, that would work out best. And then we'll leave time for that where you can either ask or type it into the chat window. So I think we'll go ahead and get started with our first speaker. So our first speaker today is Patty DeCourt, who is a nurse practitioner. Patty received her BSN at UNC Greensboro, her MSN at George Mason University, and her postmaster's certification in pediatrics at the University of Virginia. Patty has worked in peds pulmonary for 30 years, the last 15 years as a nurse practitioner. She enjoys working with all aspects of pulmonary care, including BPD, chronic lung disease, asthma, and cystic fibrosis. She is the Pediatric Cystic Fibrosis Program Coordinator, as well as the Newborn Screening Coordinator. So Patty, I will let you take it away.
Good morning, everyone. Thank you so much for the opportunity to talk a little bit about asthma first thing in this morning. As you said, I'm with the Pediatric Lung Center with Dr. Clayton and Asefa currently. We'll be moving over to PSV. So pretty soon I'll be saying I'm the Pediatric Pulmonary Nurse Practitioner with PSV. That happens on October 25th. So we're looking forward to that and excited about those new opportunities. And just a little quick housekeeping thing. If you're in the community and you're thinking, oh my goodness, you can still call our office currently through the 22nd. Unfortunately, we are not scheduling new patients at this time. We just ask you to call if you have urgent needs, and we'll discuss how we need to handle that. But we need to limit how we're handling patients right now, just so we don't lose things in the transition process. So that's all my housekeeping for that piece. I forgot I have to advance my own slides. So our objectives today is we're going to talk about the asthma guidelines and the updates that just occurred, what kind of reasons you would look for to refer to specialists, and then talk about the medications that are used as well, and some of the changes that have happened. So just briefly to start out, what is asthma? As we all know, it's a chronic reversible airway obstruction, chronic inflammation, lots of reasons why that can happen. Kids can be also just hyper responsive. They may not have as much inflammation as they are just really what we call twitchy and respond very quickly to something. I like to show these pictures in the rooms and a model if I have it to kids because they really respond well and understand what's happening inside their body. If I can show them, this nice open airway versus a clogged airway and show the bronchoconstriction around that airway. A lot of times I'll tell them it's like being in the car with your parents. And if it's not rush hour, you can get from home to where you need to be really quickly. It's a wide open highway, but if it's rush hour, it's all clogged up and all tight down. And everybody goes, oh yeah. Even the little kids go, oh yeah. So that kind of brings it down to their level where they can understand it. And the parents can make more sense of it if you see it. I think talking about it, words are great, but sometimes people always say a picture's worth 1,000 words, and it really does make a difference to see that. For some reason, I'm not advancing. I just got bumped off. Bear with me while I try to find my document again. All right.
Hi, our apologies. We're having a little bit of technical difficulties, but we'll be back with you guys in just a moment.
Okay, can you guys see my screen now? Are we back?
Yes.
Okay, there we go. Okay, so we had just talked about the asthma definition. I apologize for that. So then when we know what asthma is, but then you've got to diagnose it. So when you get to the diagnosing part, it's not always easy. Sometimes it seems pretty straightforward. And you think this is pretty much asthma. It's got a standard pattern, that episodic history of coughing and wheezing, shortness of breath with exercise. But other times it's not the easiest thing. So you really do want to stop and take a good look at your history and physical. That's basically how we make the diagnosis. Particularly in younger kids, they're not able to perform pulmonary function testing. So you really have to rely heavily on the history and the physical from the family. And even the kids will tell you, how they're feeling and such. When we're in the office, in our office, we use screening spirometry. I don't have the ability to do full pulmonary function testing currently, but we rely on the screening spirometry. A lot of times we'll use a pre and a post. We'll have a pre-bronchodilator spirometry done, and that spirometry measures airway volumes. It gives you your total volume, your forced expired volume in 1 second, and a mid-range volume. And so we measure that first before a bronchodilator is administered, following ATS guidelines, administer bronchodilator, and then repeat that test and look for what change or response there is to albuterol. And that gives us a bottom line too. Also, if a patient's saying, well, just albuterol doesn't work, and that helps us confirm whether or not it does change their airway and give them significant increase in flow. I have exhaled nitric oxide listed there. We don't use that very much clinically. in our practice had looked at it and discussed it, but a couple of issues. It's a little more challenging to do. There's a little more restriction. It's not as restrictive as it was before as far as what you've had in your mouth as far as eating or drinking prior to the test. But on the other hand, too, we have issues with reimbursement. It's so new that payers don't want to pay for that right now. And also the studies haven't quite confirmed that it provides as much support for the diagnosis and details that you need on a daily basis. We also use impulse oscillometry, IOS. And what IOS tells us is it measures airway reactivity and responsiveness, resistance and reactivity. So resistance is how easy is that for that air to move through that airway or bronchial. And that is a measure of inflammation. We also measure reactivity. How twitchy are you? How likely are you to start coughing or wheezing when you've been exposed to a trigger? So those are studies that we'd use. You can also use methacholine challenge or cold air challenge. Those are little higher level tests that we will use a lot of times if we get to the point where we really can't get a diagnosis. Excuse me. You always want to look for and exclude other possibilities. So for the most part, as I said, your diagnosis is based on your history and physical. Things that you think about when you're listening to your history and physical that really increase the probability that you're looking at a diagnosis of asthma would be a virally induced cough and wheeze pattern. So you know that it's a kid that every winter, every time the cold and flu season starts, this kid coughs and wheezes. But there's distinct patterns of illness alternating with wellness. So gets a cold, coughs and wheezes, clears up and is completely healthy until the next cold comes through. A lot of times it's worse at night. You'll hear parents talk about this kid coughs in the night. It's, or first thing early in the morning, wakes me up and I'm hearing cough through the night. Symptoms a lot of times will occur in response to their triggers, if you know what their triggers are, and sometimes teasing that out kind of helps. If you have a kid that's allergic, that's sleeping with a cat or a dog, obviously that could be a trigger if they're allergic to those specific animals. Cold air can trigger symptoms, emotions, laughter, physical activity, all those things can trigger symptoms. So you want to be sure to ask what kinds of things make you cough and wheeze. And times there are times when symptoms occur outside of the cold season, outside of that seasonal pattern, they're just a kid that coughs and wheezes year round. If you have a patient that has that triad of allergies, cough, wheeze, or asthma, and eczema, particularly if there's a family history of that, much stronger probability that that child is looking at a diagnosis of asthma as well. And then do those symptoms respond to asthma therapy? If they do, then obviously that's a really big clue that we're probably looking at a diagnosis of asthma. And this one is my favorite. You hear this almost out of every parent. They'll say, I've got 3 kids. 2 of them don't have asthma, 1 does. And the kid with asthma, every time they get a cold, it goes straight to their chest. The other 2 kids have a cold, they weather through it, they're fine in 7 to 10 days. And this kid coughs and wheezes, and it just lingers 2 weeks, 3 weeks, and I just can't keep them clear. So that's another thing to make them think, to make you think it's more likely going to be an asthma diagnosis. I also discussed when we're talking about triggers with exercise, if particularly this last year with the pandemic, people have been more, I should say less active, more of a couch potato, as we all have been. But if you have been pretty sedentary and all of a sudden decide, I'm going to go play basketball or play soccer, you don't really go from being a couch potato to being a star athlete overnight. So sometimes symptoms that are experienced are deconditioning. So you need to have that conversation and have patients be realistic about what they're experiencing. If they've had coughing and wheezing in the past related to exercise, we will go ahead and treat them as such and say, use your bronchodilator before you go in. Give yourself 2 to 3 weeks to get reconditioned, and then take that away and see if those symptoms are still there. So then we talk about some red flags. Because everything that coughs and wheezes is not asthma, as you know, but it's just some couple things just to throw out there. If you've got a little one, an infant that's had symptoms since birth, unlikely to be asthma. It's going to be more likely to be something that's an anatomical disorder or like primary ciliary dyskinesia, something that's going to present early from birth, and you're going to have those symptoms on. If you've got acute onset of a focal wheeze, you've got one spot that you're hearing it, Think more about foreign body aspiration. That's a very, sometimes not even thought about in the overall scheme of things, but always think about that if it's just a local wheeze, but not diffuse. Think foreign body and question that history. Chronic productive cough, think about bronchiectasis, cystic fibrosis, PCD again. And we've seen recently more in cases of protracted bacterial bronchitis that just doesn't clear with albuterol or bronchodilators, and it just lingers and lingers, but clears with antibiotic courses. So that's one to think about if your current therapy is not working. Feeding related symptoms, think about obviously with reflux and aspiration. I always ask parents how the feedings are going. Are there choking, gagging episodes? And maybe not even a choking, gagging episodes, but they notice a baby re-swallow or young child re-swallows frequently. That increases my concern for the risk of aspiration. I ask little kids, do they ever feel throw up in the back of their throat? Get real simple language so that they understand what you're talking about. And a lot of them will answer yes, and the parents are like, they never throw up. Yeah. And it's not that they actually have obvious vomiting or even an obvious burp or spit up, but kids will feel gastric contacts come up into the back of their throat, and they're aware of that, but because it's them and they do it all the time, they don't think it's anything unusual. So they just don't say anything about it until you ask. Again, perinatal history, surfactant deficiencies. Stridor, always think about vascular rings and slings. They're not very common. That's that zebra thing, but sometimes it's out there. And if you've got something that's just not responding to typical asthma treatment, think about that. Get a barium swallow, look for that structure and see if there's anything tight on that trachea that's causing that noise. Failure to thrive, again, cystic fibrosis or PCD. Cardiac anomalies can play into this as well. And I've listed feeding disorders again there. Mouth breathing, if you've got large tonsils and adenoids that are causing obstruction, if you've got any kind of extra compression on there where you're going to have more inspiratory stridor. Chest deformities, you're thinking more of cystic fibrosis or a really severe asthmatic that has been not treated and non-adherent with therapy for some time. I talked about foreign body aspiration. Clubbing is a late sign of chronic lung disease. So then we talk about what are our goals of asthma management. When we get through all this red flag and we get down to the diagnosis of asthma, and we're thinking, okay, now what do we do? And why are we doing this? And what are we establishing with the families? So the families, I always tell our families, our goal is to have the most normal lifestyle, the most boring lifestyle you've ever had. I want you doing everything you've ever done. The kids should be able to run, play, any sport or activity they want to do with no symptoms or very minimal symptoms. And no attacks or no flares, no big exacerbation, no emergency room visits. I always feel like if I can prevent it, if I can't prevent it, there's one thing, there's always those outlying cases that you can't prevent. But I feel like if I haven't given a parent or patient the information they need to work with and they land in the ER because they didn't remember, didn't know to start their albuterol early and aggressively, that I failed them and aided in their trip to the ER. So I always want them to know that. No airflow limitation for peak flow, peak expired flow we measured at 80 to 85%. That being said, we don't typically use a peak flow meter. I'll go ahead and throw that out there now. We don't use those in kids very often. The times that I would choose to use a peak flow meter are kids that just don't have a good recognition of their symptoms. They don't have an appreciation of how severe their symptoms are. I'll have them use a peak flow meter and during a period of wellness, document their average peak flows. And then when they start to see those numbers change, have them correlate that change in the numbers to what they're actually feeling. Because I have had kids with severe asthma walk in and say, oh no, I'm fine. And their FEV1, their forced expired volume at 1 second, is significantly down. Their mid-flow ranges are way down and you can barely hear breath sounds, but they think they're fine. That's just where they live. So helping them learn to recognize that. The real reason we don't use it very frequently is the peak flow meters are easily manipulated. And you don't want to think people do that, but some people will. So we just haven't found it to be the most reliable source. We prefer that whether it's mom and dad or teachers at school or daycare, that they look at the child and see what does that child look like, and actually do a quick look over, once over, are they working hard to breathe? Are they struggling? How much coughing and wheezing is actually happening? We're looking for minimal use of albuterol bronchodilator, less than twice a week, and the least side effects possible in all of this. Okay, so I know we've all seen this stepwise approach. Excuse me one second. And so we've seen this kind of stepwise approach now for several years. They just re-updated this, the National Asthma Education and Prevention Program updated the guidelines back in December. So I'm going to go through this and we'll talk about what the steps are and talk about what's new and changed. So first step, this is 0 to 4 age specifically. If you are a kid that is intermittent symptoms, you have that perfect cycle of episodes of coughing and wheezing, you respond to treatment, you're clear, and then you have another episode. We use just short-acting bronchodilators. In the past, that's all we had used. Now what they're recommending is that we start at the beginning, as soon as you have an onset of viral symptoms, is that you add in inhaled corticosteroids for 7 to 10 days. So you would continue your albuterol every 4 hours, but you would add in either Flovent or budesonide or Asmodex, whichever inhaled steroid the insurance coverage will provide, and have them use that Flovent 2 puffs twice a day or budesonide 0.5 milligrams twice a day until all those symptoms go away. Then they stop the albuterol and the inhaled steroid again. The next time it flares, you start the symptoms again. The catch with that is you need them to monitor how frequently they're doing that. If they're needing to do that cycle frequently, if they come in and telling you, well, we've done our sick plan 4 out of the last 5 weeks, we're stepping up now. We're headed to step 2, where you've got persistent symptoms, and they probably need to be on daily inhaled corticosteroids at that point, and you use your short-acting bronchodilator for rescue. You can add in montelukast at that point, Singulair. We in the past have used it quite a bit, but as you're aware, there are black box warnings on that for suicidal ideation. We've seen it provoke some anxiety, behavioral disturbances, sleep disturbances. So it's a good medication when you tolerate it, and it works, it's great. When you don't tolerate it, it's not very good. So we have definitely become a little more cautious in our use of Singulair. Cromolyn is Intal, and Tylate is Nidocromil. Sorry, older medications that are used very rarely anymore. If you're not staying controlled at that point, you're stepping up, you're having more symptoms, you're going up to a medium dose ICS, and still you're short acting. Step 4, you're going up to a combination therapy with a long-acting bronchodilator and short-acting for your rescue inhaler at that point. Again, adding in, you can go back if you prefer not to do a combination, you can do just inhaled steroid with or without a montelukast and short-acting bronchodilator. In step 5, you're up to high-dose inhaled steroids and your long-acting bronchodilator, albuterol as needed. Or you can increase, again, your inhaled corticosteroid dose, add Singulair and short-acting. And step 6, again, is everything in step 5. And now you've either added in Spiriva, long-acting muscarinic, or oral steroids on a regular basis. You can also be adding in short-acting albuterol at that point. When you're going through these steps, and this applies to all the steps, the first thing you want to do is you've given a plan of care, have the patient come back in and check for adherence. I always ask the patients to tell me, or the parents, tell me what you've actually been doing. Don't tell me what I told you to do. Don't tell me what you think I want to know. Tell me what you're actually doing. And the difference in that, it makes a huge difference, because if I'm thinking that they're actually doing 2 puffs of Flovent twice a day, and this kid's still not controlled, I'm going to step up that therapy and add on again. But when in reality they say, oh, well, we kind of forget, and we only do the Flovent a couple of mornings a week, and we never get it at nighttime. That's the big difference in management. So then we just step back and re-educate and help parents work through a plan to how to make it part of the daily routine so that they can actually be adherent with that. Because you really don't want to add more burden of medication and treatments if we don't need to. Always check their inhaler technique. It's surprising to me how often people forget proper technique to use their inhaler. We always use a spacer device, an air chamber, a valved holding chamber, OptiChamber is another brand, to deliver any of the HFA meter dose inhalers. The benefit of using that is it allows the propellant and the medication, when you spray your medication, your inhaler, the plume comes out and your propellant and your medication separate. You're able to take a slow, controlled breath and actually deliver that dose of medication more effectively and efficiently into the mid airways and the lower airways even, as opposed to not using a spacer. That inhaler goes straight in your mouth. A lot of the medication, a majority of it, attacks the back of your throat, slides, you swallow it, and it doesn't cause any harm to swallow it, but it certainly doesn't help your airways very much if it ends up in your stomach. So we review that quite frequently. And also not just HFAs. If you've got a patient that's using a dry powder inhaler, review that technique as well. One of the challenges we run into is if you've got a patient using albuterol HFA and they've got a dry powder inhaler for their routine controller, is remembering which one is a fast, deep breath, which one is a slow, controlled, deep breath. And then always step back that therapy when you need to, just up or down. If you're controlled and you're doing well, you want to see them control for at least 3 months before you start stepping down. If you step down too soon and symptoms come back, just you step right back up. Then what's new for the ages 0 to 4, the changes that have happened? I did not put slides side by side, but I'll go ahead and talk through this. So the first thing is what we talked about. If you've got those intermittent symptoms, you're going to use your short-acting bronchodilator every 3 to 4 hours, and you're going to add in an inhaled corticosteroid for 7 to 10 days. Typically, if it's a really young infant using a nebulizer, you're going to use budesonide twice a day. We typically go with 0.5 milligrams twice a day, or you're going to start Flovent. And if it's somebody that's not typically on inhaled steroids, I'll start Flovent 44 and start low. Use 2 puffs twice a day for that 7 to 10 day or till symptoms resolve. They also further defined for this group recurrent wheezing. It's like we talked about a minute ago. It's those cycles of episodes of cough and wheeze that clears, and then you have a well episode, a well time, and then you have a sick time again. And that's the ones that we start to worry about the pattern is when you've had 3 episodes in your lifetime, or if you've had 2 episodes of wheezing within the last year or 12 months. Our goal is, 2 episodes with no symptoms in between again. The goal is to react quickly with albuterol and put those inhaled steroids in to decrease the risk of having to use the oral steroids at that time. And one of the key things that I found with this is always give a written plan. People smile and nod, and I'm guilty of this myself when I'm at my own doctor's appointments. I smile and nod, and if I don't write it down or type it into my phone, I get home and think, uh-oh, now, which did they say start first? So it's helpful. And I tell families that, I'm very honest. I said, none of us can remember all of this information at one time. So have it written down, put it in your phone, put this on your refrigerator so you have it there and you can see what you need to do. So the next group is the 5 to 11-year-olds. Their first step is going to start with just your short-acting bronchodilators as needed when you have symptoms. Their step 2 is adding in the low-dose inhaled steroid and as needed short-acting bronchodilators. If you have a person that's already on inhaled steroids with their short-acting bronchodilator, you don't increase the inhaled steroid for an acute illness. In the past, we've done that. The studies have shown it doesn't provide a huge benefit to do it. So the recommendations actually from the NAEPP is to not increase that dose, just to leave it the same. If you're on Flovent once a day or budesonide or Asthmanex once a day, just leave it once a day. Start your short-acting bronchodilator until those symptoms all resolve. Again, you see that you can add in leukotriene modifiers, Singulair or Crumlin or Intol, which we don't use very often. They do have theophylline on there. Honestly, we haven't used oral theophylline in a long time in our practice. I remember that from my young days as a nurse. Fresh out of school, we use theater sprinkles a lot, but we don't see that very frequently anymore. Step 3, you're going up. You're thinking about medium dose inhaled corticosteroids and your short-acting bronchodilator. You also are looking more now with a low-dose ICS and formoterol. Formoterol is what was trade name was Foradil years back when you could have it as an individual medication. It is the long-acting bronchodilator that is in Symbicort and Dulera now. And Symbicort is the drug that was the study drug that these recommendations are based on. So you would step up, you would start with low dose, you're going to step up to step 4, go medium dose, step 5, obviously high dose, and you're just progressing through that each time. And you'll see that it's very similar step for each age group. Now it's just the dosing will be different. You're going to assess control. So we talked about before, these kids now are old enough to tell you, how well they're feeling. Sometimes parents aren't necessarily aware if kids are having symptoms at school with PE or recess. Parents may not even be aware if it's not enough that it catches the teacher's attention. So always include your kid's name, in there and ask them how they're feeling. Parents are surprised sometimes what kids will tell us when you ask them specifically that question. Okay, so what's new for 5 to 11? As I said a minute ago, if the kids are already on daily control or inhaled corticosteroids, it's not recommended to increase that dose for acute symptoms. The caveat there is that if you're having lots of episodes, then you're going to go ahead and step up. That's when you're doing a step up in therapy to either go to twice a day or change the concentration of the medication up front. Now, in the 5 to 11-year-old group, steps 2 to 4, they also add in to consider allergy or immunotherapy. Because if you've got a kid that has allergic triggers, taking those triggers down and controlling that will reduce your asthma exacerbations and reduce the need for medications or reduce the load of the steroid exposure. So always think about that if it's a kid that has that seasonal pattern or have them seen by an allergist to see if it's something that's perennial that they're dealing with. And then the big change for this 5 to 11-year-olds is they're doing what's called SMART therapy. It's a single maintenance and rescue or reliever treatment, SMART. And that is using Symbicort, formoterol, and budesonide. So you can start these on, you'd start with low dose and work up. And we'll go over dosing in just a bit. One reminder with this is if you have a kid that's on Advair has salmeterol with fluticasone. Salmeterol is, Ceravent was the trade name for that one, but its onset of action is not quite as effective as Foradil, so it's not been recommended to be used in the SMART therapy. And if you're on Advair, you do not want to add in Symbicort or Dulera to that Advair. So you wouldn't do that. You would just simply use a short-acting bronchodilator at that point in time. And then when these kids hit past step 3 and 4 and you get to steps 5 and 6, you're doing the same kind of SMART therapy. You're thinking about your other things, your add-ons, and biologics come in then, which are becoming more and more prominent in use in these populations. Excuse me. So 12 and older, same kind of steps. You're starting short-acting bronchodilators. You're going to low-dose inhaled steroids with short-acting or as needed concomitant. So again, back to that pattern of you've got someone who has intermittent symptoms, that doesn't need medication except when they're sick. We would have them start at the onset of symptoms, start short-acting bronchodilator, add in their inhaled corticosteroid. They use them both until all symptoms resolve, and then they stop everything again. In step 3, you're going to go right on up, start with the SMART therapy. And that just progresses on through steps 4, 5, and 6, as we talked about before. We thankfully in children, we don't see a lot of step 5 and 6. We see step 5 fairly commonly in our office. Step 6, thankfully, is pretty rare because then you're talking about being dependent on oral steroids. And we really are using a lot more biologics in this situation to have those kids be able to decrease the amount of steroid that they're on and work with them on how to wean down that therapy. As with all the both other groups, you got to check control. You got to make sure that kids are doing what they are supposed to be doing, how they're supposed to be doing it, and not just carrying it around and telling you what they think you want to know. So what's new here? And this is a busy slide. I apologize for all those little words on there. We're talking about the use of the SMART therapy a lot here. But starting with the lower steps, again, it is not recommended that you increase the dose of inhaled corticosteroid if you're on a daily dose of inhaled corticosteroid. So if you get sick and you're on Flovent or Asthmanex once a day, you continue once a day. Or if you're doing 1 puff twice a day, you continue with your maintenance dose of inhaled steroid, but you add on albuterol short-acting bronchodilator. One of the recommendations that I haven't quite got comfortable with this one myself, on a regular basis, is they recommend using 2 to 4 puffs of a short-acting bronchodilator, albuterol, followed by 80 to 250 micrograms of beclomethasone equivalent, and beclomethasone is QVAR, every 4 hours as needed for symptoms. It comes with recommendations. We just have not adopted that and started with that yet. Again, a written plan is essential in these situations so you don't end up with somebody that gets off track and continues using a steroid at a high dose for too long of a period of time. And this is another time that it's a good thing to think about, particularly teenagers that deny symptoms or don't have an accurate perception. Either they think they are much more sick than they really are, or they don't have any awareness of how sick they are. That it's a hard way to be, but those kids you've got to think about, and they may not be the best kid to add those, to use those kind of add-in where you start just a really intense therapy at the onset of symptoms. They may be a better person to keep on a daily inhaled controlled steroid, add on the short-acting bronchodilator as needed at that point. With these older kids, again, in the 12 and older, you're looking at using allergy therapy to negate those triggers. And SMART therapy is really important. One of the downsides of using the SMART therapy, and this is one that I won't say it's easy to work with, but it can be worked with, is you may need more than 1 inhaler per month if you're using that same inhaler for your maintenance and for your rescue. It's just a matter of how you write the prescription, and then you may end up having to do prior authorizations, which is the bane of everyone's existence right now. Again, the caution not to combine, if you're on Advair or a combination product that contains salmeterol or Ceravent, don't combine that with combination therapy with inhaled steroid with formoterol. And looking at the dosing for your combination medication, the inhaled corticosteroid and formoterol, for maintenance, you're going to use 1 to 2 puffs, 1 to 2 times per day based on the age. You're looking at age, severity of their symptoms, and the inhaled corticosteroid dose that you're giving. So if you've got a patient and you're on Symbicort 80, 1 puff twice a day, and that kid gets sick, you're going to increase them up to 2 puffs twice a day typically. You can now even increase them up to 2 puffs 3 times a day if they're on their Symbicort, if that's their maintenance medication. The max dose that you're using is based on the formoterol concentration, and the standard concentration is 4.5 micrograms per puff, and you're going to use a maximum dose of 8 puffs per 24 hours of that inhaled steroid and formoterol. So using Symbicort 2 puffs 3 times a day is the new way to go for rescue, and see if we can control with using that. You can throw that extra dose in for the 4 treatments if you need to. We have used this prior to the SMART recommendations coming out. We have used this in our severe asthmatics. They were studying this in Europe before using formoterol. And then we've had a couple of kids that have severe asthma that we were having really difficult times controlling. And we've actually used 2 puffs 3 times a day as their controller. That is off-label, based on some studies we have seen before, but did it in combination with some research that we were involved or associated with down at UVA. And it did work, and it does appear to be safe that way. The other thing to think about is people worry about the dose of inhaled corticosteroid. It doesn't show when they've studied this that there's any increased risk of just daily inhaled corticosteroid versus this combination SMART therapy using the combination for your rescue and for your maintenance, particularly if you think about if you're not using the combination and given the benefit of the long-acting bronchodilator and you're just continually increasing that inhaled steroid dose, that burden of steroid exposure does become an issue at the higher doses. So you do worry about growth suppression at the extremely high doses of inhaled steroids. So that also gives us a benefit in being able to decrease that steroid load. So then you have your biologics. So you'll see that the generic names are there. I'm not going to try to pronounce them because they are challenging. So I'm going to tell you, I use the trade names. Xolair is the first one. And that was the first one that came out. It's an anti-IgE. It's approved for children 6 years and older. Nucala is the second one. That's Nucala. It's an anti-IL-5. It's approved for children 12 and older with severe eosinophilic asthma. Sync-Air, the third one down, is approved for 18 years or older, and we don't use that one in our practice. Then we have Fasenra, again, is an anti-IL-5, approved for 12 years and older with severe eosinophilic asthma. And the last one is Dupixent, which is an anti-IL-4R, 12 years and older, severe eosinophilic asthma. And it has an indication for eczema. And we have seen some really good results using Dupixent in kids with asthma and really severe eczema. I actually have one kid that I follow who is down his steroid dose. He's on Flovent for his daily controller, and his dose has come down by half. His skin is remarkably clear, and since he started on Dupixent. We always caution people to remember that, again, that these are add-on therapies, and we tell families you can't stop taking your daily maintenance. Yes, this is another add-on treatment, but it will improve your quality of life and how many symptoms you're having on a regular basis. These are injections, by the way. All of these are. Some are done in the office. Some can now be done in the home if the family is comfortable with that. So there's a lot of education that goes along with this. These do require prior authorizations, and that can be a challenge within itself, as you know. So all of that being said, a lot of information. When do you refer? I remember when I was in my nurse practitioner program down at UVA, and having one of the physicians that was doing a lecture said, always think about what you're looking for and what you're going to do with that information, and when do you need to send them on to the next person. So these are kinds of things to think about. If you're having a problem trying to think of when, what is the diagnosis? What am I looking at here? If you've had a hospitalization for asthma, certainly if you've had a life-threatening situation where you were either in PICU or you were intubated and mechanically ventilated, those you would want to have a referral to a specialist at that point. If you've treated a child with oral steroids twice or more per year in a year, or if you have a child that you can't get them off of oral steroids, you probably would refer those out to be able to look for those alternate therapies or add-on therapies that we could reduce that load of exposure to steroids. If you've hit step 4 and you're looking at, my goodness, I still don't have control, think about a referral it that way. If you've had a child and you've worked with them, 3 to 6 months, and you really just can't bring those symptoms under control, think about referring out at that point. Allergy-wise, if a kid has a history of food allergies, or if they've had an anaphylactic reaction to something and they have asthma, I would definitely have them see an allergist, certainly to see what other therapies need to be there. If they need to be on immunotherapy, certainly need to have epinephrine or EpiPens available. Anything else that's going to exacerbate your asthma symptoms. I have aspirin exacerbated respiratory disease there. That's not common in children because we aren't exposing them to aspirin, but it's one of the things to if you've got happen to be seeing someone that's an adult age 18, 19 that happen to be taking aspirin, to think about. I put vocal cord dysfunction up there. I wanted to mention that because vocal cord dysfunction is one of those tricky bears that people will come in and say they're wheezing, they're tight, they feel tight, they can't breathe, and you do all your asthma therapy, but nothing seems to be working. Send those kids out so we can tease out, make sure that there's not an asthma component with it. A quick, easy way to get a sense of where a child or person is feeling those symptoms is ask them to point. Just use one finger and point. Where do you feel your symptoms? If they automatically point to their throat, probably looking at more purely vocal cord dysfunction, which is not going to respond to albuterol or traditional asthma therapy. It's going to respond more to some breathing techniques and speech therapy that we refer out for. We actually refer out to speech therapy for that because that's not my area of expertise. So you see all the other things there when you're going to refer. I wanted to throw this in. I'm looking at my time to make sure we're not running out. The GINA Guidelines, a global initiative for asthma management, they had a statement. So they don't really have guidelines. They don't have the same purpose as the NIH guidelines have. But so they have reviewed stuff. They had a lot of discussion about the smart therapy as well. They also had statement concerning the SARS-CoV-2 situation. Their statement, and I thought this was important because we've said this over and over in our practice, and we answer it still on a regular basis. Having asthma does not appear to make you to be at substantially increased risk to be infected by COVID-19. And it doesn't appear to make you be at higher risk to have severe symptoms with COVID-19. So We try to reassure families that that's not been what we've seen. There certainly are outlying cases, but it does not seem to be the risk that we originally thought it might be. GINA does recommend that you continue your daily controller therapy, whatever's been prescribed, whether you're on smart therapy or if you're on just an inhaled corticosteroid on a daily basis. I will tell you from my experience over the last 18 months, some of the people stayed on their therapy, some of the people didn't. Everybody got really comfortable at home being quarantined, and they said, oh, well, we're not exposed, haven't had any coughing and wheezing, we didn't take our medicine for any time now. So we're looking at kids now going back to school in person and talking about, we probably should start these back based on your history, pre-pandemic. A lot of parents are resistant to that. So I'm almost starting back over with some of my kids and saying, okay, we're going to start at step 1 and we're going to use this intermittent treatment plan, unless you're using your sick plan 2 to 3 times a month, and then you have to go back on your daily controller. They do recommend the use of a written action plan, which I do think is critical for everyone. We agree with the GINA recommendation to avoid the use of a nebulizer if possible in your office settings. Certainly in the schools, we have parents asking if they can take albuterol with their nebulizer at school, and we discourage that, and we don't sign the forms for that because we don't want that risk of droplet exposure in the school for the clinic or the nurse that's there and the other students and people that are around them. You can get a really good dose with a meter dose inhaler and a valve holding chamber when they're used accurately. When peak levels of COVID were hitting, we avoided spirometry. We followed these guidelines, and ATS also had said just stop doing spirometry in the office at that point, even though you do have a filter in place. When the levels started to come down and there wasn't as much activity, we did resume doing spirometry in select cases, and we've increased it as time went on, but we're following cleaning guidelines and infection control from the American Thoracic Society. This I thought was also very important. And GINA guidelines, as well as our practice, recommends that anybody that's eligible should receive a COVID vaccine as well as a flu vaccine if you have a diagnosis of asthma. That's a big conversation with a lot of patients, but we do recommend it. Originally, it was said that you needed to space those vaccines apart, but I verified with the CDC website this week that they now have studied that and looked at it, and you can co-administer COVID vaccine and a flu vaccine same day simultaneously. So in summary, asthma is pretty complex. Sometimes it's pretty straightforward. It's really easy. At other times, you walk out scratching your head thinking, I don't know what else to offer this kid. And you have to go through and rethink everything and ask somebody else to look at it. A fresh set of eyes helps a lot. Inflammation is a big key factor. So anything we can do to reduce inflammation, whether it be reduce the triggers or use a medication to control that inflammation is essential. Use the guidelines just to keep yourself in focus and follow so we don't end up on really high steroid doses if we don't need it. And our goal is always a healthy, normal lifestyle. Kids that are doing whatever they want to do, up to and including, I always tell kids, up to and including being an Olympic athlete. If you want to do that, I would love nothing better than see you on TV competing in the Olympics, which always gets a big laugh out of the kids. But then you see them go, oh, okay. So they know then that I'm telling them that you can do anything you want to do. So at this point, we want to have happy lungs. That's my goal too, is happy lungs. So if you have any questions, I'm happy to have those now. And I thank you for the opportunity to talk about the guidelines.
So Christina Oldle, I'm sorry, I don't want to butcher the last name. She asks, is there any reason why a patient with asthma should not wear a mask? We had many patients call our office to request a doctor's note for their child to not have to wear a mask at school due to their asthma diagnosis.
Thank you, Christina. Great question. There is absolutely no contraindication from our perspective to wearing a mask. A lot of it is conditioning, getting a child used to having a mask on your face. I know how we all felt. I think OR nurses are born for that. They started wearing their mask all the times and they don't think anything about it. I think all of us that outside of that setting felt that sense of, I won't say suffocation, but some resistance and difficulty breathing when we first started wearing masks all the time. And honestly, depending on which face cover I use outside of work, I have episodes where I feel like, boy, I got to go somewhere and take this mask off. But there is no contraindication to wearing a mask when you have asthma. And that's what we tell all of our patients. We do not write for a patient not to wear a mask. We tell every patient that if you're in public, you're in a group setting in school or class, you should wear a mask. The face shields, I had a patient walk in the office, a 12-year-old with a half face shield on. The weird thing was it literally covered about here, didn't cover her nose at all. It sat out from her face the way it was held on by a strap, and it sat out from her face 1 inch to 2 inches. So basically all that mask did was prevent splatters touching her. She's fully exposed to any aerosol. And I tried explaining that to her and worked with her, and I'm not sure how that went across. The parents were not necessarily receptive to that recommendation, but that is our recommendation.
There's another question. If you have a first-time infant wheezer, would you put them on albuterol? No.
Albuterol?
Yeah, albuterol, sorry.
Yes.
And Buddha, there's another one in here.
Budesonide?
Yes, right away.
Okay.
Confused with wheezers and RV bronchiolitis recommendations.
So RSV bronchiolitis recommendations, those guidelines say that albuterol is not effective. They say oral steroids are not effective, inhaled steroids. So if you look at just a diagnosis of RSV bronchiolitis, that may be true. However, if I've got a kid that is coughing, that is wheezing, that's tachypnic, and has labored breathing, I'm going to try albuterol. Excuse me. I might even add ipratropium bromide in, Atrovent with that albuterol to relieve those symptoms. You'll know right away if it's going to work or not. Some kids respond to it, some kids don't. It really is child dependent, but we do try short-acting bronchodilators with that. For an acute illness at that point, if I had a positive RSV smear, I wouldn't necessarily start an inhaled steroid right at that point, but I would certainly use the short-acting bronchodilators. And I will add before I cut that off, if I'm treating with short-acting bronchodilators, even if it's RSV bronchiolitis, again, this is not what the guidelines say, but if we've got a kid that we're seeing that is on albuterol every 3 to 4 hours, and they're barely making it to 3 hours before they're really working hard and breathing faster, and we've done albuterol for 2 or 3 days now, we're going to go ahead and add some oral steroids in to see if it can reduce that inflammation that way, because it is so much more efficient, not efficient, but so much more quick response to use an oral steroid than the inhaled in that case.
Just one more question.
Sure.
How many sickness with a prolonged cough could you have before you recommend doing the steroid treatment with a cold in a child?
So I guess like my question would be is if this is just a cold, if a kid has just cold after cold after cold and has what you would consider a normal cough with a cold post-nasal drip, you've got a really bad case of rhinitis and post-nasal drip, and the kid's coughing from that, but the chest is clear. I wouldn't necessarily go to steroids with that. I would think you could try some albuterol to see if, or short-acting bronchodilator to see if that works. It may not have any impact at all. You may have much more impact addressing the nasal symptoms using we use a lot of Afrin in kids, even in very young kids, with like 1 spray per nostril, the no drip spray, just twice a day for 3 days, or we'll might use a 6-day taper on some of the older kids to get that nasal congestion under control, some saline rinse behind it. We use a lot of fluticasone or Flonase. You can use mometasone, Nasacort, any of those nasal steroids to help control some of that inflammation before you go to an inhaled steroid if the chest is staying clear and you're seeing a lot of nasal congestion, post-nasal drip, and runny nose. I think that answered the question.
It was actually more about like, you said you have a kid that like always gets sick and then holds on to a cough forever.
The kid
and that's the kid that you would consider maybe doing some steroids on, like when they get sick, you do it. Like,
so if it's a kid that's having that, so if it's a kid that's having repeated illnesses, that's one of those things where we think outside the box too. Yes, we probably, if they're having frequent episodes, we'd use short-acting bronchodilator, put them on an inhaled corticosteroid, oral steroid if you needed to. I'd also start to think about, is this a kid that did not respond appropriately to his vaccines? And we would draw quantitative immunoglobulins to make sure that immune system is functioning normally. And we check strep titers, strep pneumonia, we check Haemophilus influenza and tetanus as kind of a standard. Most everyone responds well to tetanus for some reason. And a lot of times what we find is kids just don't have an adequate response to their Prevnar or to their Hib vaccines, and we boost them and repeat those vaccines. We don't repeat a Prevnar, let me rephrase that. We give a Pneumovax 23 if you're 2 or older, and then have them have another Hib vaccine. And usually you'll see an increase or decrease in symptoms and improvement in their symptoms overall. And you can come down, if they're on an inhaled steroid, you should be able to come down once you've established that. Did that answer the question?
Yeah, thank you.
Okay.
That looks like it's all of our questions.
Okay.
All right. Thank
I'll
you so
end with-
much.
I was gonna say, I'll end with this. Everybody who puts pictures of their kids, my kids are adults now because I'm old. So I have to put my new babies up there.
Oh.
So we'll end with that. If you have dog allergies, I don't recommend this. I don't have allergies, so I live with the furry beast.
Thank you so
for the
much,
opportunity
Patty.
today.
Thanks, Patty. That was very informative. We're very excited to have you guys come on to
Oh,
this
thank
PSV
you.
team. So thank you very much.
Looking forward to it.
All right. So I think we are going to go ahead and keep moving along with our next speaker. So the next speaker that we have is Kelly Crown. Kelly is one of our pediatric orthopedic surgery PAs. She has worked at PSV for 3.5 years, but she has a total of 6.5 years of orthopedic experience. Kelly completed her undergraduate degree in kinesiology and biology at Marquette University. She completed her master's in physician assistant studies at Drexel University. Kelly works with all of our orthopedic surgeons, but predominantly covers Dr. Ludwig, Dr. Holden, and Dr. Gil Seeley in the OR. So Kelly, I will have you.
How are you? Awesome lecture on asthma. So I just wanted to mostly talk about like the most common reasons we get like gait analysis reasons for, mostly it's kids under 2 as they're learning to walk. A lot of our pediatricians will get referrals, and most of you guys are awesome and reassuring parents and being like, no, it's okay, it's normal. And the parents are like, I'd like to see a specialist. So I just mostly want to give you some more clinical information to give a parent to help reassure them, to give you guys more information about what's normal, what's not, like when should I be concerned? When do I need an x-ray? And so we'll talk about some of those things. Disclosures, I don't have any. Here's some of our objectives: learn normal physiologic gait patterns and alignment, recognize when it's within normal variance, kind of when do you want to refer to ortho, or honestly, a lot of times we get kids that should probably go to neuro, and I send a lot of kids to neuro because it's like a CP. So kind of picking up like, when is it ortho, when is it neuro, when is it maybe genetics, developmental specialist, kind of those things. And then most of the talk is going to talk about really common reasons we see kids for gait issues. So in-toeing is probably our number one most common referral. Bowing is really common in like under 2. Flat feet, we see a lot, like when do we need to treat flat feet? And then toe walking, because there's a lot of different variations on how to treat toe walking. So those are the main gait alignment issues we'll talk about. We'll talk about current treatments and debunk myths, because there's been a lot of changes since we were kids. We used to do a ton of bracing for a lot of these issues, and we don't do that anymore. So give you guys better tools and how to, I'm going the wrong way, talk about them. So here's what we're going to cover. Like I said, in-toeing, bowing, flat feet, and then we'll follow up with toe walking. So in general, I just want to talk first about like your important lower extremity exam, right? So all of this, you're going to try to screen. I want you to do first, obviously watch them walk. Always make sure they are barefoot, make sure they walk away from you and towards you, because you'll see them do different things. Always make sure their sweatshirts are off. The number of times that a kid's got like their hands in their pockets and I take their hands off and like their posturing once I have them running is through the roof, because they know how to hide those things if they're self-conscious about it. So make sure that you can kind of get them, you don't have to be naked, but make sure they're like ideally in a t-shirt or a long sleeve shirt. Ideally pants are like in shorts or roll them up past their knees to really look at their alignment. And always do running and jumping. So before that, I'll usually put them on the table. I'll look at hip motion. Biggest red flag for us is like, did this kid have like a missed DDH? So we're looking at abduction, flexion, rotation. I'll show you an example of a good alignment check in a second here. Knee rotation, always looking at, we check popliteal angles often. So that's where you lay a kid on their back. This tests their hamstring tightness, flex their hip up to 90 and then their knee to 90 and then see how far up can you bring that. And then the thigh foot angles, that looks for shin bone torsion and then ankle range of motion. And like I said, walk away and towards us. And then you can always do standing alignment. All right. I usually do it from behind and then balance, coordination. You can have them walk on their toes, walk on their heels, jump up and down on one foot. You should be doing your Gowers, looking for clonus spasticity. Consider your neuromuscular issues. Like I said, look for some posturing. I always have my kids run and jump because those really subtle neuromuscular conditions, like a kid with mild CP, you're not going to pick it up when they're walking, but you will see it when they change positions and do something rapidly. So when they turn to run down the hallway, that's when you're going to see some of that. So, oops, I have two screens going. Shoot. Oh no, I have my notes in a different section. Sorry. I'm using my husband's Mac and I don't know how to use Macs very well. Oh, I'm just opening a million things. This is where it was. Ah, here we go. Sorry. Oh, now it did it. Oh. Center notes. Okay. Oh, and the only other thing I was going to add is like, I usually have an older kid go up and down some stairs. So spoiler alert, majority of the time, there's not much treatment. It's a lot of reassurance. So first we'll talk about torsional profiles. So reasons why a kid's going to be in-toed, out-toed. So the most common reason we see in-toeing, you're going to look for femoral anteversion. So that's a turning into the side bone. Internal tibial torsion, same thing, turning into the shin bone. Metatarsus adductus, that's the foot that's curved, okay? It can be a combination of these things. I find kids with combinations all the time. In-toeing is way more common than out-toeing, so that's why we're not really talking about it. But really common reasons you're going to see out-toeing, especially in a newborn, is going to be those external hip contractures that you see after childbirth. You're going to look at that's a baby that you stand up and their feet just turn straight out. Those will self-resolve within a year. The biggest thing, and you're going to hear me say it a bunch of times today, you're making sure that their hips are in. Okay, that's the one thing you cannot miss is a DDH. So we're going to talk about birth history and things like that. So parents, I find you can say, yeah, it's in-toeing, it's normal. And parents that love when I give them like a diagnosis, I'm like, I'll figure out where it's coming from. We're going to find out the source, and then we'll talk more about what we do. The treatment's the same. If it's femoral anteversion, internal tibial torsion, or metatarsus adductus, we watch them all. But sometimes when you tell a parent like, oh yeah, it's from here, and then I think they find more kind of reassurance in knowing exactly what's causing it. So I always try to give a parent like an actual diagnosis than just, oh, it's in-toeing, it'll be better. So most kids, it's a normal physiologic variant. I tell people under 10, it's okay, as long as it's not causing a significant ability to keep up. It's not causing significant pain. A lot of times growing pains is they're going to be the reason for pain, not are in-towing. It's usually, I usually tell parents, it's from the position they were inside, right? A baby is all tucked up and in the uterine positioning, and that causes molding. And so that's why you'll see in-towing in one kid and the next child will be fine. That's why you can see some asymmetries. Now, when you talk about asymmetries, femoral anteversion is usually not asymmetric. Internal tibial torsion is more likely to be asymmetric. And so we should distinguish between normal and anatomic variants, and then our more serious structural problems. Okay, so let's see. My slides are off. So 90% of the time, these are going to correct on their own. So chief complaints, parents coming in, kids pigeon-toed, their feet go in. I always have to distinguish, like, is that a flat foot or is it like in-towing? So typically the parents most concerned because their kid trips a lot. They are like, oh, yeah, I know they're in-towed, but they trip a lot. So trying to figure out, is it causing a functional problem? Like, is this kid just 2 and they're running and jumping and trying to keep up with older kids because they have older siblings? Yeah, they're going to trip a little bit more, but, or is it a problem? Like, do we think they have a neuromuscular condition? Do they have balance issues, coordination issues? That kid might need some physical therapy. So what's important is to figure out functional deficits. My favorite question is to ask the kid, does it bother you? So parents come in and say, my kid's in-towed, they trip a lot. And I look to the kid and I go, are you bothered by it? Do you know that you're in-towed? And 90% of the time, the kid's like, no, I'm fine. And so that'll tell you a lot that it's not causing a functional deficit. I'll always say in gym class, in PE class, if they're that old, are they having problems keeping up? Are they able to run and jump normally? Are they the slowest kid in the class? Are they having a ton of pain? Developmental delays, like that's when I start to get worried. That's when I start to look into other causes. Pain, it's kind of subjective. This isn't usually likely to cause pain. The pain that you hear from like torsional problems, like miserable malalignment, where you have external femoral version and internal tibial torsion, so they're the opposite, that causes knee pain later in life. Those are your adolescent kids. It's not usually your 2, your 3-year-olds. 90% of the time, those kids have growing pains, but we're happy to sort through all that. So super important history. What age did they walk? Were they late walkers? Were they breech? That's my big red flag. Any kid that was breech that didn't get a hip ultrasound, and now the recommendation is to also get a hip x-ray at 6 months. If they didn't get either of those things, I get an x-ray in the office, because I figure if you're coming to orthopedics for issues with your gait, we should get an x-ray on you. We always get x-rays of the whole pelvis, AP, and then frog lateral, so that their legs out. That'll look at the alignment of the hips. Were they premature? Did they have a complicated birth? So I'm looking for, is that kid more likely to have a cerebral palsy? Do they have a brain bleed at birth? Were they in the NICU for a long time? Did they need CPR at birth? So kind of screening questions for picking up mild cerebral palsy. Were they the firstborn, right? The intrauterine packaging deficiencies, right? The metatarsus adductus is more likely to be present in a firstborn kid than like your third kid. So like I said, able to keep up, and then pain. Because later in life, like after 10, that's when we care about the pain. So in-towing under 10, it's typically normal. I might do an x-ray on that kid. I might send them to physical therapy if they're struggling to keep up, but 99% of the time, it's a lot of reassurance. So how do you figure out where it's coming from? You need 4 main measurements, okay? So hip internal and external rotation, that'll look for your femoral anteversion or retroversion. We look at the thigh foot axis or an intermalleolar angle. There's kind of 2 ways to look at tibia rotation. And then the foot, we're going to look at the lateral border and how that is curved or is it straight. And you can kind of look at the heel bisector. So, and then finally, we're going to have the kid walk and look at the foot progression angle. And you can get a measurement off of baseline and kind of get your angulation. And that's usually the sum of the other 3 that you're going to see. Okay. So there's a couple ways to measure some of these things. So here's a very standard common exam. Okay. So down here, I hope you guys can see my arrow. First, you can have the kid walk, or later you can have the kid walk. I tend to examine them while I'm talking to the family and then have the kid walk. But their main concern is walking. So a lot of parents will be like, just watch them walk. So it depends on the order. But ultimately, you're gonna look at the foot progression angle. So you can draw an imaginary line on the ground. I personally think it's easiest to measure a foot progression angle from behind. I like to look at like how many toes I'm seeing. There's like the too many toes sign for flat feet. Well, I also consider it for in-toeing too. If I'm kids walking and all I can see is their big toe, they have like an foot progression angle of like 10, it's not that significant. If I can see the whole foot of the kid from behind, yeah, that might be something to watch. Same with out-toeing. If I'm only seeing like 3 toes on the outside, it's not significant. But if their foot's at like a 45-degree angle out, that's more likely to cause some functional problems. So then the 3 measurements you want for your femur, your shin bone, the tibia, and the foot, you can all do with the patient in a prone position. And so that's why usually you'll see a thigh foot axis or angle for the tibia. So you lay the baby down, put their hips on the ground, flex their knees up, and then where is my mouse? There it is. You're gonna look just straight down the leg, okay? So right here, the important thing is a kid will try to pull their feet in, pull their feet out. You got to get them to relax, which is why I don't always do this one. But the biggest thing is line up the thigh and then the foot, right? Thigh foot angle. Normal is neutral, and then internal is going to be internal. So internal 10, not severe. Start with going to 20, 30. That's getting up there. Most commonly as a child gets older, you will see this rotate out. And then our normal variable after 10 is going to be around 20. So then you take their legs and you rotate them out. And remember, internal rotation is when you put the legs out, and external rotation is when you put the legs in. It's the opposite. So our internal rotation is when you're going to see femoral anteversion. We say abnormal is over 70. So if I can lay a kid's leg down on the table, might be doing something. But what I really care about is if I can put their leg really far out or internal rotate them, but I can also come the other way, like 45 degrees, not going to cause a functional problem because they have symmetric, they have the ability to internally rotate and externally rotate. That kid's probably just ligamentously lax. So when I'm concerned is if I have a kid with a lot of internal rotation or external rotation, and they don't have rotation the other direction. So that's going to be more concerning. That's more likely to cause a problem. And then look at their feet. Same thing as the thigh foot angle. You need them to relax. And so I'll commonly have to take their foot and kind of just wiggle it and jiggle it and get them to relax. And what you want to do is look for a straight lateral border. If that border is curved, then you might be dealing with metatarsus adductus. And we can kind of categorically look at how severe it is based on looking at a line down the heel and seeing which toe it intersects from. So we'll talk about that in a second. So femoral anteversion. So femur, femoral anteversion, internally rotated. So it's excessive internal rotation of the femur. You will see kind of kissing kneecaps. So when they stand, their kneecaps, instead of facing you this way, they'll kind of be looking in. We see an egg beater gait. It's a common reason why parents will bring, especially girls are more likely to get femoral anteversion. Girls in at like 7, 8, it's because when they run, their legs kind of saucer around to the side. In the little kids, parents will say, oh, they W sit. W sitting is okay. I always tell parents, for you, you don't have femoral anteversion anymore. It's more common for you to Taylor sit or crisscross applesauce sit. Their bone is rotated in, so that is more comfortable for them. There's a ton of studies that show that letting a kid W sit will not cause prolonged femoral anteversion. Okay, so you can let your kids sit however is comfortable. If they like to W sit, let them W sit. You don't have to like run over and go get them out of their W sit position like we used to. Okay, so like I said, hip internal rotation over 70, that's when I start to like raise my eyebrows a little bit. But I have plenty of kids who have internal rotation of 70, but they have external rotation to 45, 50, and they're fine. 80 is kind of moderate internal rotation. 90, if I can take your leg and lay it on the ground, that's severe. But the biggest thing is we look at their age. So a kid is under 10, I'm going to watch it. I'm still going to give the body its natural ability to unwind with time. We're still not going to treat it. And we're going to watch until 10. After 10, we'll talk a little bit about it. So the next one is internal tibial torsion. That's excessive rotation in of the shin bone. Most commonly it's our toddlers. Most common complaint is tripping. I also always remind parents, toddlers are not very coordinated. So it's usually a toddler that's got like a 4-year-old brother and they're trying to keep up and they're like, well, my other kid did this and they were jumping just fine. A lot of times it's just not coordinated enough and the parents are kind of expecting a little bit too much. But that being said, kids that are in toe do trip a little bit more. Their toes are in and so they tend to catch them. So kind of work on their coordination is kind of what we recommend, because unfortunately there's no way for me to rotate your leg out other than doing massive surgery. So you will see parents that'll complain of tripping. If it's excessive and it's causing coordination issues, then that's when we consider PT. But I always tell parents, PT is not to correct the alignment. It's very important that we express that to our parents, because I have plenty of parents that are like, we've been doing PT and we don't notice a difference in their rotation. They're not going to. PT, bracing, shoes, they've never been shown to be helpful. The only thing that's helpful is time and surgery if we have to do it. A lot of times we do not have to do it. So observe them when they're sitting on the exam table for internal tibial torsion. As their legs hang down, you can kind of look at where do their feet lie, because that will look at an angle measurement more like their intermalleolar angle. And that's one I tend to use a little bit more, but honestly within our practice, you'll see both because they're both accurate. So what you do is you take the top of the tibia, the 2 condyles, and you measure there, and then you go down to the ankle and you look at the medial malleoli and the lateral malleoli, like the 2 big bumps on the ankle, and you put your fingers on those. And then you look down their leg, okay? You look down the leg and you see how much are those rotated. Most infants are internally rotated. Newborns, internally rotated, like 10 degrees is normal. 4 is average. A 2-year-old average will be at 0. And then by 10, most children are at like 15. 23 is the average for an adult. And so over time, that shin bone will rotate out on its own. And so you can kind of get a sense of like how severe is a child's in-toeing with that measurement as well. Because as an infant, some infants will be at neutral, some infants will already be externally rotated. It depends on the position that they were in utero. And then always look for internal rotation when the chief complaint is bowing as well, because the tibia, when you look at it in the front, it's a straight bone, but when you rotate it, it's got a curve to it. And so you will see parents complain and talk about bowing when it's really internal tibial torsion. So that's my caveat about in-toeing and bowing. So metatarsus adductus, this is most commonly in the first year of life. Again, it's more of a packaging disorder. Firstborns, it should be flexible, okay? You will see us cast these if they're rigid, and it's usually a little bit later. We give it a chance to correct on its own. We'll tell some parents to do stretching, but kind of there's mixed data on that as well. A lot of times it'll improve on its own, but it's just a gentle stretch. They hold the heel, stretch the foot over. If the mom wants to do that with diaper changes, it makes them feel like they're doing something, but in general, research has shown that it'll correct on its own unless it's rigid. And that's when we'll do casting, kind of similar to our Ponseti club footing casts, but usually for a shorter period of time, and they don't need the heel cord tenotomy at the end because there's no equinus, there's no the foot going down, it's just that curve. So a curved foot in the first year. Later on, most people will complain that their shoes don't fit well. When their shoes don't fit and they're having foot pain, that's when we would do something about it. But you're going to look at the heel bisector angle. So you're going to draw a line from the heel up to the toes. Typical, it intersects between the second and third toe. Metatarsus adductus is going to intersect between the other toes. So you're going to draw your line up. If it's like fourth, fifth toe, that's more severe. You can send that to us. We'd be happy to look at it. Curved lateral border versus a straight lateral border. A kid can hold their foot curve, so make sure they're relaxed. And then, like I said, flexible versus rigid. Okay. So imaging, I always tell parents, unless you're looking for a hip issue, this is a rotational problem. So x-rays are 2D images. This is a 3D problem. So I 99% of the time not going to x-ray this kid either. So they're not helpful unless, like I said, you're making sure that they don't have DDH. We will use a CT scan if a kid is over than 10 and they're having a lot of problems for surgical planning, mostly with our femoral osteotomies. Our tibial osteotomies, we can get measurements in the OR. using special equipment. And so you won't see us get a CT scan before tibial derotational osteotomy, but you will before the femur sometimes. And that's kind of surgeon preference. So treatment, I kind of alluded to this. I always tell parents there's 2 treatments: time, we wait minimally till 10. I can't tell you how many parents come in and they're like, well, we were told it would get better by 5. Like most of them do get better by 5, but I would kind of preface and would love if pediatricians could kind of start to tell parents 10. 10 is our cutoff. The majority of these will self-correct. There's nothing you have to do. There's nothing you need to do. I know that's very hard for, I mean, as I have 2 little kids too, it's hard to hear that, like, you're just going to watch it. Parents want to feel like they can do something about it. They want to make sure that they didn't miss something, right? That's the biggest worry of all parents. Did I not do something? And now my kid has this problem. Was that my fault? And so I always tell parents, it doesn't matter what you would have done before 10, you can't fix this. My favorite analogy is this is a problem inside the body, in the bones. They're rotated. I can't put something outside the body to rotate it out. So other than time, the other thing we have to do is surgery. And so then we only do surgery if it's very severe and it's causing functional problems. The biggest caveat and the thing I tell parents with the surgery, it's not time sensitive. So the surgery we would do at 10 is the same you would do in the adult practice in like 20. It's a derotational osteotomy. It's a big surgery. You cut the bone and you spin it. You have to use plates or an intermedullary rod. There's different techniques, but it's a big surgery and it's a long recovery. And so that's why we only do it for severe cases. And that's why 99% of the time, you get to tell your parent, it's okay. They will be okay. So in a 10 or older kid who can't keep up, like they can't ride a bike, they can't walk for long periods of time, they can't run, they're having a lot of pain, absolutely send them our way. We're happy to look at them. Even before then, I'm happy to look at them and reassure them if a parent is really giving you pushback. But most of the answer is we wait till 10. If at 10, they're still having a lot of pain or problems, come back then. Okay. Things that don't work: braces, shoes, PT, massages, chiropractors, all of that has been debunked. We always say, save your money, put it in college. It's not worth the money. Back in the day when I was a child, we used to brace these things, right? The big Forrest Gump braces. So I can't tell you how many grandmas bring a kid in. They're like, well, mom and dad needed braces, so I need you to look at this kid because they need braces. Even though the pediatricians have all said, no, you don't need braces. There's a ton of research out by awesome, famous doctor out of the state of Washington, Dr. Stelly, who took a bunch of kids and put them in braces and a bunch of kids and did nothing, and they turned out the same. So that wouldn't mean that the braces helped them, because otherwise this other group wouldn't have turned out the same. So I always use that example. They took thousands of kids. And so for that reason, because of that big study, we stopped bracing. You will see us use braces to help with functional deficits. So if a kid's delayed in walking and they need some support through their ankles and they're hypomobile, like, yes, we'll brace for those reasons, but you will not see us brace anymore to correct rotation, okay? W sitting is okay. In towing is actually an athletic advantage. This is my favorite thing to tell parents. The number of professional athletes that we have that are in towed is really high, especially the soccer players, basketball players, because with that in towing, you can activate the calf muscles a little bit more. And so you're usually faster. You usually jump higher. Once you tell a parent that, they're like, oh, cool, my kid's gonna be a professional athlete. So that's my favorite thing to tell parents, is just because they're in towed and they're 10, doesn't mean we have to do anything. Your kid might be the better athlete because of it, because it's an athletic advantage. Like I said, the surgery, it's not time sensitive. Send your kid in from a referral if they're having pain and functional problems. If they're just sending them to us because they're 10 and they're in towed, we're probably not going to do anything. So that's why I always ask the kid, does this bother you? Are you affected by this? Do you feel like you can't keep up? Are you having pain? The parents are probably affected. The parents don't like it cosmetically, and that's never a reason to do these surgeries. Cosmetics, not the reason. Function, absolutely. So, and another myth to debunk is there's no degenerative risks, degenerative joint disease risks with in-towing of the femoral anteversion, of internal retorsion. Miserable malalignment is more likely to cause knee pain, but not degenerative joint disease. So those are things to consider. When might we operate? Neuromuscular conditions, because those kids can't compensate for the rotational deformities and activate muscles the same way that another child could. More commonly, we're going to do it on a femoral anteversion with internal rotation of above 90, or like I said, that miserable malalignment where we've got external tibial torsion with internal femoral anteversion, because that does cause long-term pain. Internal tibial torsion, it's pretty rare. You'll see us do it, but more commonly, we're doing the femoral anteversion. Metatarsus adductus, like I said, it's issues with shoe wear after 5. Okay. So when do you want to refer? Like I said, over 10, pain and functional problems. Concern for hip issues, absolutely. Developmental delay, absolutely. Send that kid our way. We're happy to see them. Or like I said, grandma keeps insisting this child needs some braces because mom and dad wore braces. Sure, send them our way. We'll pull out the data. We'll show the research. We have the printout research study to hand to the parents to get to grandma. So takeaway, reassure, reassure, reassure. Intoing is super common. It's a normal variant. 99% of the time it will self-resolve. If it doesn't usually cause functional problems. So when it does, absolutely come see us. No brace, PT, or special shoes are going to work. I do send kids to PT if they're having weakness or functional problems from it. You can try to strengthen up the muscles. Most kids around like 5, 6, they might have weak hip external rotators. And you're sure if you strengthen up the glutes, you can kind of get that kid a little more coordinated. All right, that's my bigger talk because there's 3 parts. So, bow legs. So these are their angular deformities. So this is the normal progression that most kids go through. There's obviously standard deviations in this. Most kids at the age of 1 will be bowed, okay? It peaks anywhere between 9 months, but usually at most kids, it'll peak around 15 to 18 months. By 2, you should be straight. That's our rule. 3, you're gonna be knock-kneed, usually peaks around 4. 6, you should be out straight. I always tell parents this, when they come in for bowing, I warn them, hey, your kid's gonna go knock-kneed next, because I don't wanna save their time. I'm happy to see them, but I want to save them their time when they're concerned about, oh my gosh, they went into knock-knee now. So that's our general kind of spiel we always tell kids. These are physiologic genu varum, genu valgum, then they should be straight. And most typical adults have about 7 degrees genu valgum is a standard, but there's normal variants that go standard deviations outside of that. So this is what this is my favorite picture. I always show all these parents. So important history, risk factors for pathologic genu varum. So this is what we want to worry about, right? So we know that there's physiologic genu varum, but when am I going to be concerned that it might not be physiologic anymore? So my early walkers, way more likely to bow on us, right? They are heavier. They walked on those bones before they fully ossified. The bone's going to bow more. So 9, 10 months is what I'm talking about. Kids are obese, right? More weight through those bones. They're more likely to bow on us. My biggest risk factor is I'm always trying to screen for the mother that was breastfeeding and wasn't aware that her kid was supposed to be vitamin D supplement, or kind of forgot because maybe they were kid 3, 4. That's when you're going to want to screen, because that's a risk for rickets, and that we can treat. That kid just needs to go on vitamin D, but that will be excessive bowing. Family history is another factor. And then something I didn't put on here is race. Blounce or infantile genu varum is more common within our African-American, Afro-Cuban population and Afro-Caribbean. So clinical exam. So you're gonna look at the mechanical axis, laying and standing. Always looks way worse when they're standing. So lay them down, put them on their back, bring their legs together, kneecaps pointing up, take out the internal tibial torsion, and see when their ankles touch, how far away are those knees? I use my fingers. So how many finger breadths away? So you can measure and see, is it getting better? Is it getting worse? Because usually when you're going to have a kid come in, it's going to be closer to the age of 1 and it's going to be bad. And then you're going to want to say, yep, we're going to watch it until 2. And then you can get an idea how we're progressing, kind of using an objective measurement. So like I said, I lay them on their back in a supine position, bring their legs together, turn their kneecaps up, and then see how many finger breadths away are their knees. And you can do the same thing for genu valgus. Their knees will hit first and see how far away their ankles are, okay? For Blounce, you're gonna wanna do a cover-up test. So this kid actually isn't bowed through their knee. This kid's bowed through their shin. So this is tibia vera. This would be more of a risk of Blounce if they're over the age of 2, okay? So that's a good test to do. So we do get x-rays on these kids after the age of 2, okay? So it's a standing x-ray, hip to ankle, leg length. We measure the mechanical axis. So we take from the center of the femoral head, we draw a line down to the ankle. We want it to bisect through the knee. Before 2, we don't do this because you can't make the diagnosis of Blount's until 2. And like I said, it is very normal and is likely to self-correct. So that is more of a reassurance. Come back at 2. If your kid is still bowed, I'm happy to do an x-ray. Or if the parent's very, very concerned, or you want to see any hip issues, we can do an x-ray for that. After 2, we absolutely get an x-ray. We get the standing leg length evaluation. We do a mechanical axis. We'll look for a Drennan's angle. I'll show you a picture of that in this slide here. And then after 6 to 7, same thing for gingivalgum. We'll decide, does this kid need what's called a hemiepiphyseodesis? Do they need that surgery to shut down half of their growth plate so that they can grow out of it? Do they need assistance growing out of the angular deformities? So the angular deformities are more time sensitive. So here is 2 kind of pathologic issues, right? Blount's, what everybody's always worried about, but it's pretty rare. I think we only have maybe 2 kids in our entire clinic practice that have Blount's right now. Children's, I think, sees a little bit more than we do, but I just want you to know it is pretty rare. But happy to send them to us if they're bowed over 2. So what you're looking for is this beaking and this fracturing of the epiphysis. What it is it's a sick growth plate off the medial proximal tibia. Rickets is going to be more of a mid-shaft metaphyseal widening. And this is going to be the kid that most commonly, the United States doesn't have a problem with it as much as other foreign countries, wasn't vitamin D supplemented in a breastfeeding mom. But there are other endocrinology reasons for low vitamin D or vitamin D deficiency. So you're going to want to run a calcium and a phos if you're really concerned about vitamin D. I saw a study recently that said like 75% of kids are low on vitamin D. And I think that number went up to like 80% with the pandemic because people weren't going outside as much. And so most kids, if they're not vitamin D supplemented, they get their vitamin D from the sun. But we lather our kids up in sunscreen if you're fair skinned. And then the darker your complexion is, more less like the melanin levels, you're not going to absorb it from the sun as much. So we do see a fair amount of vitamin D deficiency in our practice, and we'll test for that for fractures and other reasons too. So treatment, most of it is reassurance because the majority of kids that get sent to us for bowing are under the age of 2. Okay, so under the age of 2, we watch it. I will test a vitamin D if I'm concerned they have any of those risk factors. We can always test a vitamin D and then supplement, and that should get better. But a diagnosis of Blount's can't be made until 2. So if you're concerned by bowing at 2, absolutely send them to us. Like I said, rickets, if we find rickets, we send them to Children's for the bone health clinic. So next is flat feet. We see a lot of flat feet. There used to be.
How are you?
Hey, someone's microphone is on.
That's an expensive drink. My goodness.
Hello. Might be in like a conference room or something, or if you could just mute your mic, that'd be wonderful. Thank you. So flat feet. This is a normal, like if you had a kid step in a puddle of water and you had them stepping, this is what their footprint would look like. Kids don't develop an arch until the age of 5. And if they don't develop one, it's genetic. It's either mom or dad is flat foot, maybe grandma or grandpa. Kids that are ligamentously lax, so your kids with Ehlers-Danlos, they're more likely to be flat-footed. And I always tell parents, it doesn't matter what you put in their shoes. There's no way, same as the rotation, there's no way to create an arch from shoes, orthotics, without, it's just genetics. If a kid develops an arch, it will happen naturally. There was really interestingly a study that came out in 2003 that showed that kids that wear shoes in the house at younger ages, like 2 and under, they're more likely to be flat-footed because there's a thought that they're not using the intrinsic muscles of their feet to develop the arch. So there's kind of like an intrinsic muscular component, and then there's also the genetic component. I just find it interesting. I'm a big advocate for kids being barefoot to help with balance and coordination too. I think that sometimes the shoes are very clunky, but you will always find parents, and they ask all the time, I'm sure your pediatricians can attest to this. What's the best shoe for my kid? Should my kid be in a stride right? Should they be in leather shoes? Should they be no shoe? Like parents really like to talk about shoes, and studies show that the shoe wear doesn't matter. when do I care about flat feet? I care about flat feet when they cause pain. Oh, sorry. I wanted to show you this. So this is how you're going to look for flat feet. Always look from behind. And you're going to draw a line down the calf muscle, kind of down the Achilles tendon, and then look at the position that the heel is sitting. So this is going to be in calcaneal valgus. Okay. And then we're going to talk about when do we care about it? So when they have pain. I don't want kids to be in pain. That's kind of my big, okay, we should do something about it. But if a parent brings a kid in and they're 3, 4, 5, even 7, 8, 9, and they have flat feet, but the kid doesn't have any pain, I say, okay, yep, you're part of the 20% of the population that has flat feet. And we don't have to do anything about it unless you have pain. If you have pain, then we should do something about it. Because most people that are flat-footed are actually asymptomatic. So pain will be typically with activities or after prolonged walking. It can kind of be in a bunch of different locations. This is what you should help you make your differential diagnosis of, is this just a flexible flat foot that's causing impingement syndrome or pain? Or am I dealing with something else within the foot? And do I need to get an x-ray? Big red flag is if it's rigid. That's a sign of another issue. So how are you going to tell that? You need them to be barefoot. Look at their foot sitting. Most kids with a flexible flat foot will have an arch when they're sitting on the exam table. And then when they hop down, arch goes away. That's more likely to be a flexible flat foot. Then when they have pain, you want to localize where it is and see if you can reproduce it. A lot of kids with pain from flat feet, you can't typically reproduce that pain. So let's see if you can do that. So here is my exam for flat foot. So look at them on the exam table, have them stand up. So here, they'll draw the line down the back of the leg, look at this Achilles tendon, and then see the position of the heel. So this left foot is in more valgus than the right. This one's mild, this one's pretty severe. Then you have them go up on their tippy toes. Does it correct into varus? These heels don't kick in as much as most kids that I see. Most kids' heels will kick under. If their heels don't kick under, then you're concerned and you focus on that foot and you say, am I dealing with a rigid flat foot? Or flexible flat feet should kick under. So valgus when they stand, varus when they go on their toes. The other way to check for a rigid flat foot is to look at their subtalar motion. So while they're sitting, you take their heel, you cup it, and you wiggle their foot side to side. It should move a lot. It should be inverted and expert. You should be able to supinate and pronate it without pain or difficulty. If you do, then you are most likely want to get an x-ray and look for tarsal coalition. So when the bones in the foot might be fused. Always look at their heel cord tightness. So the gastric and the soleus are the two muscles back there. You do it with their knee straight and their knee bent because there's two muscles. You can have one tight and one loose. The tighter their heel cords are, the more likely they are to have pain with their flexible flat foot. And then this is a Brighton score. This is looking for hypermobility. My favorite one, I just start with their hands. If they can touch their thumb down to their forearm and they hyperextend their elbows, do the rest. But usually if they can't touch their thumb to their forearm and they don't hyperextend their elbows, they're not going to meet the criteria for the Brighton score to look for hypermobility. I just think it's an interesting fact. I don't think that every kid with hypermobility needs to go to genetics. Maybe someone from genetics will disagree with me, but I have hypermobility and it doesn't affect my life. So that's why I refer for pain. It's just more likely that the kid will be flat-footed. So other common things to consider in your differential diagnosis: heel pain in an active 8 to 11-year-old, intermittent limp. Think of your severs, right? So that's that growing apophysitis that you can reproduce with a calcaneal heel squeeze test. You can push on that heel and that heel hurts. They jump off the table. The accessory navicular bones. We think that like up to a third of the population has an extra bone down there, but we don't care about it unless it hurts. Same with the flat feet. Don't care about it unless it hurts. But if they point straight to their navicular bone and they have flat feet, they are more likely to be symptomatic. And you can have both. Flat feet and accessory navicular bone, we are more likely to need to do surgery to take out that extra navicular bone, or the little ossicle that's there. It's usually smaller. Because they're going to be symptomatic, because they're going to collapse through the midfoot, and that posterior tibial tendon that attaches there is under a lot of stretch and that pulls and it irritates. So you can have both, but look for pain there at the navicular bone. Tarsal coalition. Oh, my slide cut off half of this. Whoops. Tarsal coalition. So that's you're going to do that subtalar motion. You can also have a calcaneonavicular coalition as well. That's going to be pain more down the midfoot on the lateral aspect. a common history is they have multiple ankle sprains. If you have a kid who's had multiple ankle sprains, get an x-ray of their foot, make sure they don't have a tarsal coalition. It's more likely in our 9 to 12-year-olds that they're going to start getting pain as their foot slowly ossifies. Last is the Kohler's disease, pretty rare. Again, it's going to be pain at the navicular bone, intermittent limping. Usually it's a heavier kid. It's as that navicular bone is ossifying, you can get pain from like a pseudo-AVN. It's kind of similar to the perthes of the foot. So keep those in mind. X-rays, I get them if they're pain or they're rigid. Make sure they're standing. You want the oblique view to look for coalitions. If they have a painless, flexible flat foot, I don't get x-rays. Don't expose your kid to radiation if you don't have to. If you suspect a tarsal coalition and you don't see an x-ray, you can have a fibrous coalition. Then we sometimes get CT scans, or first get an MRI, and then we'll get a CT scan for surgical planning because the size of it will dictate what do we do. So here's your x-rays. So normal's on the left, flat foot's on the right. We're going to look for talonavicular uncovering. So this bone is over to the side. We draw a line down the talus and it should intersect with the first ray. Here it does not. I don't need an x-ray to see this. So that's why a lot of times I don't get x-rays on these kids. I'm like, I know you have a flat foot just looking at your foot. So we don't have to do x-rays just to diagnose flat feet. Same with this. You look at the calcaneal pitch, look at Mary's angle. This is the line down the talus, down the foot from the lateral view. So you can see that this kid, calcaneus is up. This one is flat. I don't need an x-ray to do this. So it's more for surgical planning. Tarsal coalitions, you're going to see a C sign. So this bone totally fused. There's no sinus tarsi. And then on the oblique view, there should be a gap between the talus or the calcaneus and the navicular. And here's your coalition. Okay. I don't expect you guys to know this, but thought to share. So treatment, nothing if they have no pain. Okay, there's no way to create an arch except for doing surgery. Special shoes, custom orthotics, they actually haven't been shown to be more effective than the over-the-counter ones, and they're very expensive. And kids don't typically like them because they're plastic, and kids run around a ton. So they do better on more of, you have to have some support through the midfoot, but they do better a lot of times on these over-the-counter ones. And I'll show you some examples. They're about 25, 30 bucks, not these rigid ones that the orthotics companies make and the podiatrists make, because they're too rigid and running on plastic doesn't feel good. Pain and disability, sure, let's treat it. So I start with custom or over-the-counter orthotics. Here is an example. This is a brand that's on Amazon. It's Kidsole. They have, see this plastic black part through the midfoot, and then this green and through here is cushion. So it's a combination of midfoot support with a lot of cushioning. That's for kids under size 4. I'll send them online. Most kids under 4 don't have pain with flat feet. Over size 4, I actually send them to the running stores. We have some awesome running stores in the area, Potomac River Running, Pacers, Metro Run Walk. They have treadmills, and they have these things that you can stand on and look at the severity of the flat feet and recommend an orthotic for that. All the people in those stores are specially trained to fit orthotics, and they're designed for runners. Kids are constantly running. So a lot of times this is all they need. They're about $50. Superfeet is a really common brand that you'll see. It's still cheaper than the custom orthotic. So custom orthotics don't work as well as the over-the-counter ones. Why would we spend extra money on the custom ones? So we start with the over-the-counter ones. So those are my two biggest kind of things I wanted to send you is Amazon. Kidsole is my favorite brand. And then oversized 4 feet. We'll send them to the running stores and they'll take care of your kids. Therapy will do if they need some heel cord stretching, ankle strengthening. Surgery is based on pain and disability. Okay, if it's affecting their activities of daily living, a kid can't run, they're not even able to walk, then we'll do surgery. The gold standard is soft tissue with bony osteotomies. Okay, it's a big surgery. It's soft tissue releases, tendon advancements, osteotomies, which means we're cutting the bone. So we think a long time about, do we need to do this for this kid? Sometimes we absolutely do, but it is a big surgery. I will caution you, I've met some wonderful podiatrists, but there are some procedures that they do that I've seen recommended for kids that are not successful. So mostly it's a subtalar arthrodesis implants. They work great in adults, but studies show that about 30% of kids still have pain after they do the surgery. So what they do is they put a little screw in the subtalar joint. A lot of times they'll grow out of it, they fall out. We've seen some nasty complications. So I would not recommend, this is we're in ortho surgery, you send your kid to podiatry for podiatry surgery, other than ingrown toenails, fungal issues, those kind of things. But for bony structural components, podiatrists are not usually specially trained in treating kids. So please, that's my one caveat about podiatry. Also, they make money on their orthotics. All right, last, I know I'm kind of running up into time, is toe walking. So there's a wide range of toe walking treatments out there. Most of your toe walkers are going to be kids under 2. It's idiopathic. They are just, that's the way they learn to walk. Okay. Even after 2, majority of the kids, it's idiopathic toe walking. We don't know why they decided to do that. That's the way they learn to walk. The biggest problem with toe walking is if you continue to walk on your tippy toes, your heel cord in the back will get tight. And so most kids, as they get older and more coordinated, they will come down as long as their heel cords have not tightened up on us. As they get bigger and heavier, they'll come down. But I've seen lots of kids that don't. And so I think most of our practice is more likely to treat toe walking with braces and therapy and stretching casts, because we don't want to do surgery on these kids. We don't want your toe walking and your heel cord tightness to progress to the degree that we have to do surgery. So I'll tell you what I do, and what there's probably one doctor and one PA that doesn't do this, but everybody else I think follows this treatment plan. And then this is what was also on the PODS, not like Pediatric Orthopedic North America recommendations. So biggest thing, you want to screen for neuromuscular conditions. Your cerebral palsy kids, your autism kids, those are more likely to continue to toe walk as the kids with autism. It's a sensory component that's part of like stimming. And so it's harder to get that kid to come down. Also doing the behavior modifications, reminding a kid, walk flat, walk flat, walk flat. They're not going to follow the directions as often. And then cerebral palsy, they just have spasticity. And so that kid is tight. And also I want to tell you, they will toe walk because they need it as a mechanical advantage. So sometimes it's not a good idea to correct those kids that are hemiplegic CP and get them all the way down, because if they have like a fibular hemiamelia, you want to leave that leg short. They need it for propulsion. So there are some times where you will see us not get a kid flat, but in general, the general recommendation is get the kid down, get them plantigrade for better walking mechanics. Okay, so most of this talk is for idiopathic toe walking. Our biggest factors of treatment is age and heel cord tightness. Okay, once a kid starts to be around the age of 5, I find those kids don't tend to come down, especially if they're really high tippy toe walkers. If they're a kid that's just kind of floating and their heels like this far off the ground, yeah, that kid will probably come down in the next year or 2 as they get bigger and older and go to school and notice other kids don't toe walk. Sure, I think it's fine to watch that kid, but if you have a kid way up on their tippy toes and they're 5, that's when I start treating. So important factors, have they always walked this way? I had a girl who was 15, didn't always walk that way. That was concerning. She went to neuro. Can they walk flat if they want to? Like if dad says, walk flat, can they go down? That means that their heel cords are probably still flexible enough. Are they able to run and keep up? One girl so tight and high, she couldn't even jump. So I'm more likely to treat her. Birth history, is there a risk for cerebral palsy, speech delays? Are we looking for autism? So heel cord strength, flexibility, same as the flat foot. Gastroc and the soleus. You can be tight for one and not the other. So get your dorsiflexion with your knee extended and the knee flex. We're more likely to see tightness with the knee extended than with the knee flexed. So want to look at their standing alignment. They're really, really tight. Their feet way off to the side now. Do they have like a significant flat foot because of their heel cord tightness? What's their preferred way to walk? I want to see how they toe walk. How high are they? Are they way up on their toes? Or are they able to come down? And are they just, like I said, it's kind of skim across the ground? Can they walk plantigrade? If I asked you, can you walk flat? If a kid can do it, that's awesome. If they can do it, but their feet are out like 90 degrees, it doesn't really count. In my mind, it's like, yes, you get points for getting your heels down, but that's not functional. The biggest thing is to look, can they walk on their heels? So yes, they can go down, but do they have enough strength, one, through the tibial anterior, and flexibility to get their toes up and walk on their heels? That's concerning when they can't do that anymore. I'm more likely to treat that because that tells me that they're tightening down on me. Can they run and jump? Okay, really tight, can't do that. Always look for clonus. This is when I'm going to start kind of sending into neurology. When do you refer? I think a great age to send a kid with toe walking to us is around 5. A 5-year-old who is still toe walking, they're starting to get tight on us usually. And 5-year-olds don't care about wearing braces. There's a huge social implication to putting a kid in a brace. A kindergartner is more likely to get excited about a Paw Patrol brace or a butterfly unicorn brace on their legs and not care and not get picked on than a kid in 2nd grade. So that's my other kind of caveat to this is you can wait, but the chances of us needing to do casting and bracing is higher, and a kid is not going to be as compliant in those braces the older they get. So any significant delay, spasticity, consider neurology, right, prior to ortho. I still want to see that kid, absolutely. But if they have something neuromuscular going on, they are more likely to regress on us, and we are more likely to need to do surgery or serial casting or be more aggressive with our treatment. So if you have a kid that has a significant delay, consider doing neurology and then us. That would be awesome. Any age, and they can't dorsiflex calf neutral, I need to see that kid. So treatment, like I said, mostly divided by age and tightness. If I can't dorsiflex you past 0, you need to cast. If you're really far off, like 20 degrees off from dorsiflexion, then we might talk about surgery because I can't usually get that length in a stretching cast. So the stretching casts, they are put on once a week, and cast room, they go all the way to the knee, and we push and we try to push them down. And then I do want that kid to walk in their cast. They do get some calf spasms and tightness, so every once in a while we'll prescribe some Valium. But usually, depending on the degree of how much dorsiflexion they're missing, typically I'll do like 3. Every once in a while we'll need to do 4. I've had a couple kids where I need to do just 2 stretching casts, but it's a once a week cast. And then what you want to do is you want to go from the cast into the brace. I don't want to stretch you, and then you go back up on your tippy toes and we lose all the stretch that we got. So under 2 is just typical. I just say watch it. Try your best, do behavior modifications. When you see the kid toe walking, tell them to walk flat. Say you can come up with a keyword. You say purple when they're walking on their tippy toes if they're more self-conscious and a little bit older, that only you and the kid know that they are toe walking, and to remind them to walk planogram. 2 to 4 if they're flexible, behavior modifications and stretching. I keep that kid stretched. And then you can consider PT if you want. I don't find it helpful. I think mostly they need to do stretches every day. After 5, that's when we consider doing bracing. It's a full length AFO. My favorite Achilles stretch is this one. You can do it on a step. Most kids that are younger have a step in their bathroom to brush their teeth on. You can do it while you're brushing your teeth. It takes 2 minutes, 30 seconds with your knee straight, 30 seconds with your knee flex, switch. That's 2 minutes. Your dentist would love you if you brush your teeth that long. So it doesn't even have to be an extra activity during the day. You can do it while you're brushing your teeth. Is my favorite. Yeah, twice a day. Okay. Or any stair in the house. So this is the hinged AFO I use. It's got a plantar flexion stop. So the reason it works so well is, one, you're trying to break a habit, right? This kid only knows one way to do it. When they're told to walk flat, they can, but that means they have to think about it all day long. This makes a kid not have to think about it all day long. Their brace is going to make them walk flat. And all day while they walk, they're going to get that dorsiflexion. They're going to stretch out for us. So that's why I brace, is 1, to break a habit, 2, to stretch them out. You do this in addition to daily stretches, okay? They have awesome patterns. You can make them fun. Like I said, it's more likely easy to get a 5-year-old and a 6-year-old to wear one of these. We do typically have to do them for about 6 months to 9 months is my average, because you're breaking a habit. Kids been walking like this for 4 years. Serial casting if you can't dorsiflex past 0, surgery if they fail conservative treatment, or if they're very contracted. After surgery, they go into casts and they still wear AFOs. So ultimately, all of these kids end up getting AFOs in our treatment. That's it. I know I ran over like a couple minutes. I'm sorry. Anybody got questions?
Kelly, there's a couple of questions in the chat if you want me to read them, or if you want to read them. It's up to you. Okay.
Yeah. All right, let me see. Scroll. Babies who are breech should have a hip ultrasound, yep, at 6 weeks. And then they all now, the recommendation is a hip x-ray at 6 months, correct? There was that is a newer recommendation this year, is because that's the more the developmental, DDH is developmental hip dysplasia, right? That's more the developmental component to it. You can have a baby that has normal hips on their 6-week ultrasound and then develops hip dysplasia later, and we'll watch that kid. So now then, yes, the recommendation is hip ultrasound at 6 weeks for all breech babies, or actually twins too, and then a 6-month x-ray. You can do it in your office or our office. Fairfax Radiology has pediatric radiologists that review them, and so they do a really good job of picking up any mild hip dysplasia issues that you will see on x-ray. So yes, that is the new recommendation. Moderate to severe pronation. Oops. I don't know why I can't control this. Here we go. The same as pes planus. If they complain of pain, do you recommend orthotics? Can pronation eventually cause knee pain in teens and adults? Excellent question. So yes, pronation is technically through the midfoot. Calcaneal valgus is hindfoot. They're both synonymous with flat feet. What you care about is it flexible or is it not? There is no association between hip and knee arthritis and flat feet. There is association between flat feet and ankle pain and pain, sometimes knee pain, but not, people always think, oh, my kid has flat feet and it's going to cause hip and knee issues later. That's been now debunked. So yes, you can call, some people are like, oh, they pronate, so they have calcaneal valgus. Those in my mind are synonymous. Those are just different therapy terms. Technically, like I said, pronation is through the midfoot. I've never seen pronation without calcaneal valgus. So you can use whichever term you prefer, but yes, those are both pes planus. Did that answer the question? I hope so. And for twins, yes, I would do both. I think it's an ultrasound and one small x-ray is not going to harm anybody. I'd rather pick it up, but that's just being maybe cautious. Did I do the rest?
Kelly, this is Lila Gata. I had one question. When you order the x-ray at 6 months for the hips, how do you write it?
Oh, x-ray pelvis.
Okay.
Frog lateral. You want the whole pelvis. You want both hips. So it's not a hip x-ray, it's a pelvis x-ray. Yep.
Okay, thank you.
Yeah. And I think there's more questions in here.
I think
No,
that is
that's
all
it.
the, yeah.
Okay.
that's all
I was like, I'm seeing answer questions now. Okay. Anybody else?
All
And like I said, everything I talked about today that came from mostly PAWS now, which is the Pediatric Orthopedic Society in North America. So they have awesome handouts and references to OrthoKids. If any of the pediatricians want them for their office for in-towing, bow-legged, we will commonly hand a kid a handout from those places. All right.
Well, thank you, Kelly. That was a great talk. Thanks so much. So we're actually going to take a quick break, everyone, just like a stretch break. We're going to come back and start around 11:15. So the next talk will be from GI, from Bernadette, and that will be at 11:15. So we'll take a little break and then we will see you back in about 10 to 15 minutes.
Is still here. We're going to go ahead and get started again. So this is going to be our last speaker of the morning, and then we'll have a lunch break, and then the afternoon will start at 1. So our next speaker is Bernadette Diaz. Bernadette received her BSN from George Mason University and her MSN at Marymount University. She is a nurse practitioner who has worked in peds GI for the past 13 years. She has extensive experience caring for children who have feeding difficulties. She has also published a chapter in the Handbook of Pediatric Gastroenterology regarding failure to thrive. So Bernadette, whenever you're ready, you can go ahead and get started.
Hi, everyone. Let me share my slides with you. All right. Can you see it? Are we good? So anyway, thank you, Neha, for the nice introduction. And as Neha said, I've been in pediatric GI for a very long time, maybe longer than some of you have been out of school. I mean, a lot longer. Anyway, one problem that I see a lot is failure to thrive. For my learning objectives today, I hope to make you understand the medical meaning of failure to thrive, understand the pathophysiology of pediatric failure to thrive, identify the key components of evaluation and diagnostic testing, discuss common treatment options, and recognize red flags and differential diagnoses. The definition of failure to thrive. Failure to thrive occurs when an infant or child fails to gain weight or grow. It's not a specific diagnosis, it's more of a descriptor. Other descriptors that you hear is malnutrition, failure to grow, poor weight gain, growth faltering. The traditional definition of failure to thrive is weight below the 3rd or 5th percentile for age, or on more than one consecutive measurement, or when weight declines and crosses at least 2 major percentile lines, or when weight is less than the 3rd or 5th percentile on the weight for length curve. I wanted to touch a little bit on malnutrition. So more and more, we are moving towards defining failure to thrive as malnutrition. As I said, failure to thrive is a symptom, not a diagnosis, whereas malnutrition is a diagnosis that more accurately describes inadequate nutrition and can be determined via clinical assessment. The American Society of Parenteral and Enteral Nutrition, ASPEN, the Academy of Nutrition and Dietetics, the A&D, and the American Academy of Pediatrics define malnutrition as an imbalance between nutrient requirements and intake, resulting in cumulative deficits of energy, protein, and micronutrients that may negatively affect growth, development, and other relevant outcomes. So they identified 4 categories to look at, which includes Z-scores for weight for length, BMI for age, length, height for age, and mid-upper arm circumference. So with those factors, then you can classify the kid as having mild malnutrition, moderate malnutrition, or severe malnutrition. But going back to failure to thrive, so the prevalence of failure to thrive, it affects about 10% of kids in primary care and accounts for up to 5% of referrals to subspecialty practice or hospital admission. Males and females are equally affected. It's usually associated with low socioeconomic status, low parental education level, and increased psychosocial stressors in the home environment. There are 2 types of failure to thrive: non-organic failure to thrive, which accounts for 90% of cases, and organic failure to thrive, which accounts for 10% of cases. Organic failure to thrive is when there is an actual medical disorder that is leading to the lack of necessary calories to grow. These include inadequate caloric intake, increased loss of energy, increased caloric demand, or altered utilization of nutrients. So kids who have organic failure to thrive can be kids that have neurologic disorders, which impairs their swallowing, injury through their mouth or esophagus, congenital anomalies such as the kids with tracheoesophageal fistulas, cleft palate, tongue tie, which is becoming more commonly diagnosed these days, chromosomal abnormalities, diseases leading to anorexia, irritable bowel syndrome, mood disorder, eating disorder, gastroesophageal reflux, and sometimes chronic constipation. Excessive caloric losses. So some kids vomit a lot and they may have pyloric stenosis or gastroesophageal reflux, so they're losing calories that way. Some kids have malabsorption, diseases like celiac disease, short bowel syndrome, post-enteritis syndrome can cause carbohydrate malabsorption, and you have protein malabsorption for kids with chronic IBD, protein-losing enteropathies such as cow's milk protein allergies, parasite infestation, fat malabsorption from pancreatic insufficiency, and chronic cholestasis. Kids with gastrointestinal atresia or anatomic malformation are also affected, and of course, inborn error of metabolism. Some kids have increased caloric requirements, those with chronic infections or immune deficiency, congenital heart disease or heart failure, malignancies, thyroid disease, in particular hyperthyroidism or autoimmune thyroiditis, chronic lung disease, sepsis, trauma, burns, hyperactivity, and other rare diseases. The more rare cause of organic failure to thrive would be altered utilization of nutrients such as inborn errors of metabolism and genetic syndromes. Non-organic failure to thrive. So these are the majority of the kids we see. It accounts for 90% of failure to thrive. These are kids where the inadequate caloric intake is caused by poverty, poor understanding of feeding techniques, improperly prepared formula, inadequate supply of breast milk, neglect, food aversion, parenting failures, family dynamics, breastfeeding problems, caregiver problems such as depression, and lack of food availability. So these are problems that we can definitely help with. Clinical evaluation. So when a child is referred to you for failure to thrive, or you notice that one of your patients is not gaining weight or not growing, you need to do a full clinical evaluation. The most important is history, as usual. You have to look at your history of present illness, family history, social history, and of course the physical exam and possible diagnostic testing helps. History of present illness. It's very important that you look at their developmental history. Do they have some developmental delays? Birth history and prenatal history. We see a lot of super preemies these days. They're like born at 23 weeks. Past medical and surgical history contribute as well. When you do your review of systems, you should look at symptoms that may indicate any of the organic causes for failure to thrive, such as inadequate intake, increased requirements, increased losses, or poor use of nutrients. So you need to look for diarrhea, chronic constipation, snoring or mouth breathing, any kind of difficulty eating, such as dysphagia. Some kids can't breathe when they're eating, wheezing, unexplained fever, frequent infections, abdominal pain, vomiting, coughing, lethargy, hypotonia could indicate some neurologic problems, delayed milestones, body and joint aches, rashes, polyuria, and hyperactivity. Family history, we're looking at significant diagnosis such as age of onset of puberty of the parents, significant chronic illness in the family, and you're also looking at parental height. So I wanted to say though that we're lucky, I guess, at PSV because in our EPIC system, we're able to look at mid-parental heights. It computes it for you. And studies do show that 90% of children's heights would fall within the 1.5 standard deviation of their mid-parental heights. So for example, this kid is one that we've seen for a while. So she was referred to us for poor weight gain, and we followed her through the years. So in the beginning, we thought it was a problem with calories. And we also thought that it was because her parents were short. But with time, we followed her throughout. We realized that this was actually caused by a chromosome disorder. So she was finally tested for genetics, and they found a chromosome disorder, which would explain her growth. Social history. So you need to find out who family members they live with, who are their typical caregivers, community services. Are they hooked up with early intervention? Do they have an ABA therapist? You want to make sure that they have a source for food, such as, of course, insurance, WIC, mental health of the parents, postpartum depression, substance abuse, or abuse issues in the family, and poor attendance at school is the indicator of social problems. Feeding history. This is one of the more important assessments that you need to do. Are they breastfeeding or formula feeding? Are they doing a combination? Are they mixing the formula correctly? It sounds so easy. However, you do need to ask the parents, like, how are they mixing? Because sometimes that's the root of the problem. Look at their feeding schedule. Are they eating solid foods? Do they aspirate? Do they have a feeding aversion? Family dietary beliefs and practices. So some families are vegetarians, vegans, or have other special diets, and their mealtime structure. As you get their feeding history, you need to start then calculating how much calories they need. So this is one way to do it, is doing the dietary reference intake. So kids from 0 to 6 months of age need about 108 calories per kilo per day. 6 to 12 months, 98 calories per kilo per day. And kids 1 to 3-year-old, about 102 calories per kilo per day. This is a more extensive list of the same. When you're treating their caloric needs for catch-up, you need to look at increasing their calories by 20 to 50%. And for kids who do not have organic fare to thrive and are relatively healthy, you want to give them an excess of about 150 calories per kilogram per day. Physical exam, anthropometrics, which include your weight, your length or height, weight for length, or BMI and head circumference. It's very important that these are accurate. We have started to do some mid-arm circumference for older kids. And then, of course, your full physical exam. You need to pay attention in kids with fare to thrive at their skin tones. Are they pale? Do they have rough skin, hair thickness, texture, muscle development, evidence of underlying fat stores, protuberant abdomen, and evidence of vitamin deficiency, such as bowing of the legs from rickets. You need to look at red flags. These are your cardiac findings, heart murmur, extremity edema, jugular venous distension, developmental delays, dysmorphic congenital features, hepatomegaly, splenomegaly, lymphadenopathy, recurrent infections, recurrent vomiting or diarrhea, aspiration, eating disorders, and depression. These are just some of your red flags. Pediatric growth measures. So as I can't emphasize enough how important it is that kids are measured frequently, as well as that they are measured correctly. So the American Academy of Pediatric Guidelines suggested or recommend that children less than 2 years old have a weight for length, and head circumference measured at every well visit, and that kids older than 2 years of age have their anthropometrics measured at least once a year and as often as possible. The newer thinking states that premature infants should have their growth corrected until 3 years of age to account for the difference between the WHO chart and the CDC growth chart. So I'll go more into that. When you measure a kid, it's very important that you try to measure them with as little clothes as possible. So less than 2 years old, we measure nude. And the kids who are older, we measure without shoes and as minimal clothing as possible. Length should be measured with a calibrated length board. So we measure kids laying down for the first 3 years, and then we move on to standing up heights by using a calibrated stadiometer. Consistency is key, using the same scale if possible, using the same amount of clothes if possible, and of course, using the correct growth chart. So as you all know, there are different growth charts out there for different syndromes. This is just a sample of Turner syndrome, where the kids with Turner syndrome will usually grow at a shorter rate. Williams syndrome, same thing. They're a little bit shorter than normal, but that's good to know. Down syndrome growth charts. So we don't rely on the Down syndrome growth chart, but we do kind of refer to them to just reassure the parents. So for example, this is the female who at 8 years of age in the Down syndrome growth chart is in the 50th percentile. And then at 14 of age, the same thing, 50th percentile. But when you plot her on a regular growth chart, you can see that she is in the lower percentiles. And then as she gets older, she gets further from normal. So Down, as you know, Down syndrome kids are usually shorter and at a higher risk for obesity than normal kids. I wanted to touch on the life expectancy growth chart as well. So I see a lot of kids who are who have cerebral palsy, and this is stratified by GFCS, or Gross Motor Function Classification System. So this growth chart divides the kids into 5 different categories. 1 is walks without limitations, and 5 is a wheelchair-bound child. So these are different growth charts. And then in category 5, you see that they do separate the non-tube fed and the tube fed kids. So for example, this is a girl who's 16 years of age, who's wheelchair bound and tube fed. So in a regular growth chart, she's showing up here around the 50th percentile for her BMI. But then when you look at the life expectancy growth chart, she is in the 77th percentile for her BMI. So kids who are wheelchair bound and not active, we'd like to keep them on the lower percentile, somewhere around 15 to 25th percentile, and certainly not more than 50th percentile, because of their disability and the fact that, you know, as they would need their caregivers to carry them or help them with their activities of daily living. I wanted to touch on pediatric growth charts. So as you all know, the CDC recommends that the WHO charts be used for kids who are less than 24 months of age. And once they turn 2, you want to move on to the CDC growth charts. You can either use the growth chart for 0 to 36 months, or the 2 to 20-year-old growth chart. They differ in their construction. The WHO chart was made taking into consideration kids who are breastfed, whereas the CDC growth charts followed kids in the United States and watched what the typical growth is. So for example, this is a side-by-side comparison of kids using a WHO chart and a CDC chart. So in the WHO chart, the kid is in the lower percentiles. However, in the CDC chart, you would classify the kid as failure to thrive. So we've seen some of these, not very often, but sometimes we do, I guess, disagree with the referral sources regarding which growth chart that they used. Non-organic failure to thrive. I just wanted to show you some examples of some growth charts that we've seen. So if failure to thrive is due to poor intake of food, then what we normally see is that they start declining in their weight but then the height stays stable and then starts to decline as well. And that would go with head circumference as well. So this is a typical picture of a failure to thrive kid. If short stature is the issue, then and the weight is normal, then you might need to send them to endocrinology to get a workup for their short stature. So this is a child with normal weight and the height is falling down. If their weights were low as well, sometimes we push calories and just see if they're going to grow taller. Organic failure to thrive. If weight and height fall together, this likely indicates an underlying medical condition, such as this child where the weight and the height start falling at the same time. It may still be regular failure to thrive. However, you want to check if there is an organic cause to this. With treatment, our goal is catch-up growth. So these are two different kids with the same scenario, basically, where they were failing to thrive, and then slowly the heights are starting to go down as well. And then you provide an intervention such as starting them on Pediasure or even putting an NG tube, gastrostomy tube, and then you see the weights going back up as well as the heights. Anyway, this is what you want to see. I wanted to touch a little bit on constitutional growth delay. As you all know, a lot of parents say that their kid is just small because that's how their family is or their other children are. So, you know, some kids will stay in their normal growth curves or their own curves. So for example, this child, if you look at the weight and height, it's just following along. But when you see them, you know, as young kids, you don't know that that's what's gonna happen. So you do need to watch them closely, push calories, you know, just make sure that it is a constitutional growth delay as opposed to failure to thrive. If you push too hard, this is a kid who has constitutional growth delay, so they're in the lower percentiles for weight and height. However, this is 12 months of age, then we start giving them supplements, and as you can see, the weights keep going up, but the heights stay the same, and you know, this is something that we shouldn't do, of course. Diagnostic testing. So there's little evidence to support broad diagnostic screening. Multiple studies have shown that less than 1.5% of diagnostic evaluations led to an organic cause of malnutrition that was not already suggested from the provided history or physical exam findings. Therefore, any laboratory tests as well as radiology testing or endoscopy should be directed by history and physical exam. For diagnostic testing, we have laboratory testing, radiographic testing, and endoscopic evaluation. Based on their history, you want to do the more common blood tests, your CBC, CMP. Looking at albumin is important to look at their nutritional status. We used to use pre-albumin a lot. However, pre-albumin, the half-life is only about 2 to 4 days, whereas albumin is 22 days. So if you're looking at like long-term nutritional status, you want to look at albumin. If you're, for example, looking at how your nutritional intervention is working, then you can do pre-albumin because it tells you from the short term how well they're doing. Celiac disease serologies are not usually done in kids less than 3 because the results are could be inaccurate. Stool tests, depending on their history, of course. We look at fecal fat, pancreatic elastase, You want to do pancreatic elastase in 3 different days, just to make sure that it's accurate, because it fluctuates. And then for those who have fecal fat, we would send them for a sweat test for CF. So radiographic and endoscopic evaluation. In most cases, these are ordered by specialists or done by specialists, such as GI or ENT, and pulmonology as well. This is usually done when you suspect some another diagnosis, as well as when you keep working with a child and they continue not to gain weight. So you have your upper GI series to look at malrotation, pyloric stenosis, the esophagogastroduodenoscopy or EGD can be done to rule out esophagitis caused by reflux or eosinophilic esophagitis, which is a chronic condition, as well as celiac disease. We can also see H. pylori, gastric ulcers, and also test for lactose intolerance through biopsy. Modified barium swallow or video fluoroscopy swallow study can be done to diagnose aspiration or swallowing difficulties. Direct laryngoscopy and bronchoscopy or DLB can be done to rule out airway issues such as laryngeal cleft and tracheal malacia. And sometimes we send them to do this at the same time as the endoscopy so that they're not exposed to anesthesia too much. There's a fiber optic endoscopic evaluation of swallowing, which is also used to diagnose aspiration and swallowing difficulties. This is good as well because the video fluoroscopy swallow study does require a lot of radiation. Treatment depends on the cause, of course, but usually spans multiple domains. You have pharmacology, nutrition, psychosocial interventions and education, feeding therapy, and occupational therapy. Rarely we hospitalize kids with failure to thrive. This hospitalization is good when you need to get an expedited evaluation that can't be obtained in a timely manner doing it outpatient. This also includes completion of specific diagnostic tests, initiation of enteral feeds for support, and in cases of suspected neglect or abuse to demonstrate a child's ability to grow adequately when given the right amount of calories or food. Nutrition, so increasing caloric intake. So when we first see a child with failure to thrive, we try to increase calories from the foods they eat, such as adding butters, oils, cream, cheese to their foods. We also do some, interventions such as telling the parents to space their meals because when they graze, they're usually not hungry, limiting meal times to 20 to 30 minutes, avoiding overnight feeds, and replacing juice with higher calorie formula or supplements. Psychosocial interventions, as we said, feeding therapy is important. It's usually done by speech and language pathologists or an occupational therapist. And they work closely with the child. They see them pretty often. Speech therapists work on the mechanics of eating, from how the child picks up the food, chews, moves the food in their mouth, swallows, drinks liquids safely. Whereas the occupational therapists support functional feeding skills such as self-feeding, and they also manage sensory issues related to feeding. So kids who have problems with texture should see the occupational therapist as well. So what we do send them to speech therapy first for feeding, and then if they need occupational therapy, then we add that on. psychosocial interventions. You want to make sure that they have a food supply. So you want to hook them up with WIC if needed, or make sure, I guess, send them to a social worker if they need insurance. Early intervention is good. Teaching them about where they can go for food pantries, and of course, referrals to feeding therapy, and if needed, family therapy. Behavioral interventions provide strategies to improve the parent-child interaction at mealtime, reinforcing positive feeding, using positive words. So these are interventions that will help the child have a positive experience with feeding. Pharmacology, sometimes we use vitamin supplements for deficiencies. Appetite stimulants, we use cyproheptadine a lot. Megestrol is another choice, but we actually haven't used that for kids. Medications to treat underlying problems, of course. So one of the most important things I want you to know is that it's really important to tell the parents to not force feed their child. We have kids with gastrostomy tubes who are pretty normal, but have had such bad experiences when they were infants or younger kids with being force fed, and it's so difficult to treat that. Prognosis, catch-up growth. The children will typically require 1.5 to 2 times the typical amount of calories recommended for age. You are going to see a difference at about 2 weeks. You know, they are going to gain a little bit of weight, but steady weight gain may take about 6 to 12 months to see. And other special considerations include outpatient management, seeing them often, weekly, bi-weekly. It just depends on the child or the parent. It is noted that behavioral interventions can require significant periods of time. So when you send them for feeding therapy, reassure parents that it does take a long time. It takes a couple years, you know, in feeding therapy to actually really see a difference. Sometimes we send them to intensive feeding programs such as Kennedy Krieger, UVA, and VCU have programs for feeding. To evaluate treatment, so the goal of Fair to Thrive is, of course, to get catch-up weight gain. So what you want to see is that that they're gaining weight. For example, for 0 to 3 month olds, you want to see them gain 26 to 31 grams per day. That's normal weight gain. For catch-up, you want to tack on then 20 to 50% more. So I made this little algorithm of how we approach Failure to Thrive and treatment options, as we've talked about. I wanted to do a little case presentation. So this is Logan. He's 9 months old. He presents to you for a checkup. Parents say he's doing very well. He drinks about 4 to 6 ounces of formula every 4 hours, about 4 times a day. He's eating jar baby food 3 times a day. He's not spitting up. So he doesn't have reflux. He's pooping normally. Parents are mixing formula correctly, 1 scoop to 2 ounces. Developmentally, he's doing what he needs to do, such as sit alone, pulling to stand, starting to cruise. He's babbling. So cognitively, he appears normal as well. But then when you look at his growth chart, you notice that he has started to plateau with his weight gain. The height is still okay. In your physical exam, you note that his vital signs are normal. His weight is 7.4 kilos at this point, or in the 5th percentile. Height is still in the 50th percentile, and head circumference is still normal. The rest of his physical exam is normal. So then you look at his caloric intake. So if he is getting formula mixed to 20 calories per day, so that's your 1 scoop to 2 ounces usually. He's getting about 20 to 24 ounces a day, or 400 to 480 calories per day. From baby food, you have about 60 to 70 calories per jar times 3. So that's 180 to 210 calories per day. So since he's 7.4 kilograms, and you calculate that, he's getting about 78 to 93 calories per kilo per day. So that's the chart again. So he would be here, and normally he would need 98 calories per kilo per day. So our management, our goal, of course, is to increase caloric intake. He looks like a pretty normal child otherwise. So you're increasing by 20 to 50%. The recommendations, you want to tell the parents that at this age they do want to start to give him 3 meals a day with 2 snacks in between. We're trying to increase calories with the food that he's eating, and try not to give him more formula, because developmentally that's what he needs to do. So he is getting 20 to 24 ounces of formula. You could fortify that higher. You could go anywhere from 24. Sometimes we go all the way to 30 calories per ounce. We try not to if it's not needed, because it's hard on their kidneys the younger they are. So anyway, by the time they get to a year old, we are on 30 calorie per ounce formula. So Logan is 7.4 kilos. So if you multiply that by his normal needs, it's 98 calories per kilogram per day, or 725 calories. Then you add on 145 calories, which is your 20%. So he needs about 870 calories per day. And most of it we want to come from the solids that he eats. So to evaluate treatment, so as mentioned, 6 to 9 months old should gain about 12 to 13 grams per day. So he comes back to you 2 weeks later. At that time, he should have gained at least 12 grams per day. So 14 days, so he should have gained about 168 grams per day. But then if you tack on for catch-up growth, you want him to have gained 201 grams per day. Grams. So Logan should be at least 7.6 kilos at 2 weeks, if that makes sense. And if he's not there, then you want to step up on your intervention, or if needed, do some diagnostic testing. This is his growth chart again. So if he goes from 7.4 to 7.6, you do see that the percentiles have increased. So that's what I have. Do you have any questions for me? Any questions? No? Okay. So I guess I ended early. So anyway, I'll pass you back to Neha.
Thank you, Bernadette. That was great. So we are actually going to have a break for lunch now. So, you know, then the afternoon speaker will start at 1 p.m. So everyone can kind of take a break. If you want to leave the room and come back in, that's fine. I think it's probably going to stay up if people want to just turn off their, you know, camera and sound and stay in the room. But we will start back again at 1, and you can continue to use the chat box if you guys think of other questions for Bernadette, or, you know, any of the other morning speakers. We can always pass that along to them. All right, so we will see you guys back at 1 p.m.
I'm going to go ahead and get started. It's just shortly after 1. I hope you guys all enjoyed a nice lunch break. Can you all hear me okay?
Yep.
Okay, perfect. And I hope you guys enjoyed the morning session. My name is Akila Michael. I have been a nurse practitioner here at PSV for the past 5 years in the neurology department. And I have the pleasure of introducing our first afternoon speaker, Dr. Rachel Casey. Dr. Casey is the Chief Strategy Officer and Medical Director of Gynecology for Pediatric Specialists of Virginia. She is an assistant clinical professor at the University of Virginia, teaching residents and medical students at Inova Fairfax and Women's and Children's Hospitals. Dr. Casey completed medical school and residency in obstetrics and gynecology at the George Washington University and fellowship in pediatric and adolescent gynecology at Washington Hospital Center and Children's National Medical Center in Washington, D.C. Dr. Casey holds leadership positions with the American College of Obstetricians and Gynecologists and North American Society Pediatric and Adolescent Gynecology. In addition to a love of caring for children and young women, she is a passionate advocate for women's health within our local community and for national healthcare initiatives. Welcome, Dr. Casey.
I'm muted. I should know that by now. Thank you so much for that kind introduction. I'm so flattered to be here. And I'm really happy to talk to you about periods because all women or most women have them. I'm gonna just start my screen sharing here. Just a second. All right. And please let me know if anybody has trouble hearing me. I'm having some headphone issues, so I'm talking straight from the computer. Thankfully, my children are not here. All right, so we're going to talk about the menstrual cycle as a vital sign, which I was trying to think of something that would really touch on most everybody listening. It's challenging to think through what would be most educational for a crew that represents multiple pediatric subspecialties, but I think we can probably touch on most of them in this talk. I have no financial disclosures. And here are our learning objectives. So we're going to describe normal menstrual cycles in adolescents, recognize those abnormal patterns in menstruation, try to understand what appropriate workup may be for a few certain cases, and then review management of abnormal uterine bleeding in adolescents. And then I'll sort of talk through just the idea of menstrual manipulation, because I certainly get some referrals from you all to do that for some of your complex patients. So what is normal? So this is my favorite picture from this funny little website called I Heart Guts. And it is supposed to be a depiction of the menstrual cycle. And it's probably what most teenage girls actually experience, right? So the good old menstrual cycle, bloody mess, head full of hormones, egg escape, hormone party, ovulation time, luteal lunacy, hormone hell, and ova and out, right? And so you ride away on your bicycle with your period or a baby, hopefully not with a baby. But this is probably the picture that we're more familiar with, which is a scientific version of that, which I do find really helpful when we're talking about menstrual irregularities in teenagers, because I think interpreting what may be going on with the hormones at the time can help us figure out what might be going on and how to target it. And most specifically in teens and adolescents, is that ovulation. So when girls go through ovulation or don't go through ovulation, right? So when they go through ovulation, the corpus luteum is formed, and that is actually produces a hormone signal. That's what produces that progesterone. And so what happens a lot in these girls is they don't ovulate, and we're missing that hormone signal, and that can often cause a lot of the disruptions that I see or that we see. So what is normal, right? So we keep hearing all this stuff about how periods are earlier and earlier, but the average age is still just about 12 and a half. The range is wider, right? 9 up to 15 is still considered normal. Average cycle is about 32 days, and it really can be normal for it to come anywhere from every 21 to 45 days or 3 to 6 weeks in this age group. Period blood flow should really be 7 days or less. And what's really hard to determine in some kids is how heavy the periods are. So because it's so subjective and often difficult to track. But in general, we say maybe about 3 to 6 pads or tampons per day, but there are nuances, of course, of like what size they're using and leakage and stuff like that, which we'll talk a little bit about. Ovulation, that's so mainstream, right? So this is in the early years, and ovulatory cycles are very, very common and very, very normal. Even with that, cycles may still fall within that 3 to 6 week range, but may not have that ovulation every month. We have seen that the earlier girls go through menarche, the earlier that there are ovulatory cycles. And then although we believe that most girls will be ovulatory by 2 to 3 years, that some people take longer. So, I often see girls around 2 or 3 years who are having some irregular cycles. And while I do think it's reasonable to evaluate them, if everything's normal, we kind of wait it out. So the menstrual cycle as a vital sign was not my novel idea, of course. This was a really important paper, evidence-based paper that came out initially in 2006. That was a joint statement by both the American Academy of Pediatrics and the American College of Obstetricians and Gynecologists, really talking about how, as I say it, we check your blood pressure and your heart rate. We want to know what's going on with your menstrual cycle because it's a signal of what's going on a bigger level inside of your body. So when we're thinking of that and we're asking, are your periods regular or not, there are so many things that can contribute to irregular periods. I always don't forget pregnancy. I know like most of the younger girls were saying it's not at the top of the list, but it's still on the list. So never forget that. And that anovulation secondary to that immature hypothalamic pituitary ovarian axis is by far and away the most common. But I think it's really important, and I'll show this slide multiple times during this talk, because this is really where all of us kind of come together, because these are conditions that I do not primarily take care of, but you may, and this is where we kind of come together, where the thyroid, okay, I do take care of a lot of PCOS, but I don't take care of diabetes and Cushing's. I do take care of ovarian insufficiency, but some of these other like rare endocrine conditions or other general medical health conditions that might impact the periods are important, and where we kind of all intersect. The way that we've started classifying abnormal bleeding has changed. So many people may be familiar with the terminology of menorrhagia, which has always been very difficult to spell. So it's a good thing, right, that changed. So it's abnormal uterine bleeding, and then is classified further as heavy menstrual bleeding or intermenstrual bleeding. And then the goal here is kind of separating it into structural causes and non-structural causes so that we're all using the same terminology and can kind of communicate between each other a little bit better. By far and away, structural causes are quite rare in adolescence. They do happen, but it's very, very rare. And so the most common things that we see is coagulopathy, second to ovulatory dysfunction. So that's most of what we'll kind of talk about. So you've asked your vital signs, you figured out, okay, periods are not quite normal. So the next question is when do we need to worry about this, or when do we need to investigate it further? And the way I kind of phrase it to most of my patients is the first question to answer is why is this happening? And then the second question, once we understand why, is what do we do about it? And so this is also directly from that menstrual cycle as a vital sign paper. And these are the very specific, like straight out of the article about when things need to be thought of a little bit more deeply. So menses hasn't started 3 years after breast development. If the periods haven't started by 13 and there's no puberty whatsoever, menses hasn't started by 14, but with some other concerns about hirsutism, disordered eating, overexercising, or possible outflow obstruction, which actually gets missed sometimes, interestingly, seen for like back pain or chronic constipation. So probably you are seeing some of these kids and not realizing it just quite yet. Periods haven't started by age 15. They're regular, really happening every single month, and then suddenly they become irregular again. If they're happening very frequently, so more frequently than 21 days, less frequently than 45. And I would add to be, when you're asking about periods with kids, people will say, I'm getting a period every 2 weeks, but kind of clarifying those actual dates, right? Because if you're getting a period every 3 weeks and it's lasting for 7 days, there's 2 weeks in between bleeding, but the periods may still be within a normal time frame. Occurring 90 days apart for even one cycle, so missing periods for 3 months. If they're lasting too long or require frequent pad or tampon changes, so soaking through every 1 to 2 hours is certainly not normal. And then, we ask other questions about passing blood clots and other bleeding disorder concerns. As far as evaluation goes, I do find, the history is quite important. Really kind of, these aren't all the questions that I asked, but really kind of getting the full history. And I find that menstrual tracking is really quite helpful. There are really good apps. It's hard to get if they're not tracking, it's hard to get the right information. So I find the apps to be really, really helpful. But kind of getting the puberty history, the progression of puberty, certainly their last period, but really what are all those cycles before that looking like? When did things kind of go awry, and what could have happened? Always asking about pain with the periods and if that's causing them to miss school or activities, either pain or the heaviness of the period. Have they ever had treatment? Certainly anemia and the bleeding history can be pertinent, of course, for anybody with heavy menstrual bleeding. Certainly, especially in our organization, medical history is significantly important. I'm sure we do share a lot of patients with complex medical histories. Never forgetting to ask about sexual activity and disordered eating, which we'll talk a little bit about. Family history of things like PCOS are important. The mom's menstrual history, sometimes there may be an underlying abnormality that's been in the family but has not been diagnosed or recognized. And then one thing that I think is really important to note is that an internal pelvic exam is rarely indicated. And I find that when I first say that with the young girls, they like immediately breathe a sigh of relief, right? So they're like, oh, thank God. Okay, we can do this visit now. Like, that's fine. But it's more about doing Tanner staging, skin findings, and external exam if indicated, depending on what the complaint is. Probably the most common labs in OBGYN are, there we go, pregnancy tests, thyroid, prolactin, blood count, of course, and STIs. Certainly many more opportunities for labs that we'll go through a little bit. And then similar to kind of that internal pelvic exam is that, we can utilize pelvic ultrasound to really look at the internal structures, and we can use the external exam to look at the external structures. And that this is something that, although structural causes are less common in this age group, it is something that can be done only on the abdomen, not transvaginal. And that if we do need additional imaging, they can be done translabial. And of course, other imaging modalities such as MRI can be helpful in certain cases. So I'm going to go through a few cases. It's of course hard to be interactive in this format, but if anybody has any questions between each case, I'm more than happy to go through anything. I tried to think of what would be the most high yield for this group in particular, so I hope we can get a few things out of it. So this is our first case. This is a young lady who's 12 and she's here for abnormal uterine bleeding, and she's been bleeding for 3 weeks. So this is something that we see very, very commonly. Pediatricians see possibly even more than I do, because they call me about them. So periods just started about six months ago. Her last period started 3 weeks ago. And before that, it was about 45 days. So it was a 6-week gap between those two periods. She's been having them mostly in that 3 to 6 week range, and they have been lasting fairly normal, but now lasting 3 weeks. Missing school and activities, yes, because she's just having some difficulty managing her brand new periods. But hasn't had any treatment. And then confidential interview is negative, and her pubertal development has been and appears to be normal. So thinking back to that differential diagnosis and that top number 2 thing I put up here, that, anovulation, this is like the perfect example of that peripubertal anovulatory cycles. But I do think it's important, especially for the group of us here today, to be thinking about other generalized medical conditions, because certainly some of these other things could contribute to an anovulatory cycle that then ultimately becomes prolonged. And so these are still things we need to be screening for in our history and considering doing further evaluation for. So does this kid need to have additional evaluation? So the answer, of course, is yes, which is why we're presenting the case. But the true reason here is because in the last 7 days, it's been lasting for 3 weeks, right? So of course, the thing at the top of everybody's mind is she's been bleeding for 3 weeks. So is she going to become anemic? And so the workup there, of course, is ruling out anemia, always checking for thyroid dysfunction too, because sometimes that can contribute to this, even in prepubertal kids. Having prepubertal vaginal bleeding occasionally is the thyroid. So, doing that basic evaluation is what I typically do. Surprisingly, most young healthy girls do not ultimately become anemic, but it certainly can happen. And for any of you here in hematology, have probably seen the kids in the hospital requiring blood transfusions. So this isn't something to kind of sit on and wait too long. And then, as I mentioned before, considering other medical conditions and any workup that might be appropriate for other health conditions that could be contributing. As far as treatment, there is the option for expectant management, especially if they're not anemic. Like certainly starting some type of iron supplementation would be encouraged there. If there's an acute bleeding episode, certainly when I see kids who've been bleeding for 3 weeks, I think it's probably time to intervene. And there's 2 different things that I often do. One is doing just a Provera or progesterone for 10 days. And this is sort of when the girls are not going through ovulation and you're missing that progesterone from the corpus luteum, this Provera kind of will transform that proliferative endometrium into secretory. So it kind of will be a reset in my mind of mimicking that second half of the cycle and then allowing them to start over. So it will stop the bleeding for 10 days, but then they'll have another period and be sort of like a reset. Of course, if they're anemic, that's probably not the best idea because then they're going to bleed again in 10 days. So I typically would, at the very least, be considering doing birth control pills until their anemia has resolved, and then stopping, because most of these kids have an episode like this once, we treat it, and then they most often will go back to resume some more normal types of period patterns. And just again, what I was trying to explain is that anovulatory cycles, that AUVO, right? So in the absence of ovulation, the corpus luteum doesn't develop. So there's no progesterone that gets secreted by that corpus luteum in the ovary. And there's just this constant proliferative state because there's unopposed estrogen. We never got that estrogen surge. And so the endometrium just keeps shedding and shedding and shedding. And it's often irregular, like light one day, thinks it's stopping, starts again, heavier, lighter. And that's the most common pattern that I see for this. So this is our second case. I don't know if anybody has anything in the chat. If you have questions, feel free to pop them in between these cases. I'll keep an eye on that. So in our second case here, this is a little bit different. So right, a 17-year-old with irregular periods for the last 2 years, has been menstruating for several years, so for 7 years. And last period was 4 months ago. So missed a period for 4 months. Before that was 2 months. So the cycle range is really certainly outside of normal here. And notices that sometimes gets a period that's 2 days, sometimes it's for a couple of weeks, and the flow is variable, which is very common for this particular type of pattern. And then otherwise, I put this under here under the confidential interview, is screening for disordered eating, especially now because I think we've seen so much PCOS with some type of related eating disorder, either eating too much or eating too little. So I think that's something that we all need to be kind of aware of, as I'm sure many of you have also noticed. Pertinent exam findings, she is overweight, obese. Do notice the darkening on her neck, some acanthosis nigricans, and she has a little bit of coarse hair on her face and lower back and abdomen. So back to this differential diagnosis slide. Certainly if she's a 17-year-old, I actually do a beta HCG on anybody that I draw labs on. It's technically also a tumor marker, so I just draw it as routine. But certainly if anyone has not guessed it yet, we're kind of pointing certainly towards an endocrine condition, which is most likely PCOS. So do we evaluate this kid further? Certainly. So why is this happening? Why are the periods happening less frequent and so spread out? So work up here, these are most of my general labs that I do, right? So the HCG, thyroid function test, prolactin, testosterone, which is part of the diagnostic criteria for PCOS. I tend to do estradiol as well in conjunction with the FSH-LH, right? FSH is going to be ruling out primary ovarian insufficiency. And sometimes we see that LH-FSH ratio, although not diagnostic for PCOS, can be helpful in kind of thinking towards that as another concern. 17-hydroxyprogesterone to rule out congenital adrenal hyperplasia, and then DHEAS, which is an androgen that's secreted from the adrenal gland, which we do sometimes see modestly elevated in PCOS. It's not part of the criteria, but it is something that we often see, not in tumor range for adrenal gland tumor, but something that is slightly elevated. And then, of course, if they're obese or overweight and there's strong suspicions for PCOS, then ruling out diabetes and checking cholesterol as well. So PCOS, which is the name that everybody is aware of, is a terrible name, especially for our teenagers. there have long been proposals to change it to something more along the lines of functional ovarian hyperandrogenism or androgen excess syndrome. And this is because although there is diagnostic criteria that includes polycystic appearing ovaries, that is not required in the diagnosis of it. So in teenagers or in adolescents, we use the Androgen Excess Society diagnostic criteria, which is those ovulatory dysfunction, so anovulatory infrequent cycles, so some type of period irregulation, and either clinical or serum hyperandrogenism. So seeing that excess hair on the body, or having the testosterone elevated, more commonly closer to like 50 or 55. It's a little bit controversial in adolescents, simply because periods can be irregular in adolescents. Sometimes the testosterone can be variable during the menstrual cycle. So we really wait until at least 2 years from when the period first started to be talking about it and kind of talk about it a little bit more, about how it exists on a spectrum, especially in these teenagers. The reason it's important, a lot of it has to do with reducing cardiovascular risks, decreasing risk of diabetes long-term, because these are young people that we have the ability to impact and help now, and hopefully decrease these problems in the future. And then from a GYN perspective, of course, protecting the endometrium and managing those irregular periods. If there's amenorrhea or no periods for a very long time and consistent exposure to high circulating testosterone, there is a risk of endometrial hyperplasia. It's extremely rare in teenagers, but it has been reported. So I just never want to minimize that, and that piece of it is quite important. For PCOS treatment, I just had to put some little cartoons here, right? So lifestyle modifications are the #1, especially in the teenagers, because we're really trying to decrease those longer term risks, the diabetes, obesity. And what I failed to mention the last slide, although it was on there, is that one thing that I think is important and of note is that there probably are different phenotypes of PCOS, meaning that we are aware of, women and girls who may be overweight, and there's something related to that excess body fat that's contributing to the elevated testosterone and all the symptoms of PCOS. But there is probably another form of PCOS where girls or women are not overweight, and that hormone level is being secreted directly from the ovary and is not directly related to body fat. So there's a difference in kind of counseling and management for those different phenotypes, which we're still trying to understand with research. Other than that, of course, medications can be part of this for many girls. So hormonal contraception, combination OCPs work really well, and they help by actually targeting what's going on, right? So they decrease that circulating testosterone, of course, protecting the endometrium by regulating the periods. So that's most commonly what most people end up with. But of course, if people don't want to be on birth control pills, that is totally fine. If the testosterone is not too high, we can do kind of cyclic progestins about every 3 months, just to make sure we're kind of shedding the lining so it doesn't build up. And then the IUD, which you'll hear me say multiple times later, is just the next best thing to sliced bread, as they say. But that certainly offers endometrial protection and excellent contraception for girls as well. Non-hormonal medications are also often used. Metformin is definitely an option. It's been studied mostly in the infertility population. But it is also used in adolescents, in part those who are trying to achieve weight loss, certainly those with prediabetes, but it can result in regulation in the menstrual cycles. It's just that it often requires higher doses, and some adolescents may not be quite as tolerant of those GI side effects. And then certainly spironolactone is another medication that we use at times. So we'll go into case number 3. This slide is from like 6 years ago, before she was quite as famous, but this young lady here is one of my favorite people. I don't know if she had primary amenorrhea, but I just wanted to include her picture in this talk. So now we're talking about a 16-year-old with primary amenorrhea. So thelarchy, puberty started at age 12, so 4 years ago. No pelvic pain, is a competitive gymnast, and When we're looking at height for weight, seems to have a normal percentile, a normal BMI. So back to our slide on differential diagnoses, certainly pregnancy, of course, and ovulation, probably not top of the list here. I mean, this is kind of pointing right here to the acquired conditions to be thinking about, I don't know, hypothalamic dysfunction, medications, female athletes, or eating or some type of disordered eating. So certainly this is somebody who should be evaluated. Really, if periods haven't started by age 15 should be evaluated. And then also she would fall under that the period hasn't started 3 years after breast development. So it should really start about 2 years after breast development. So when we're doing evaluation for primary amenorrhea, it's a little bit different thinking for primary versus secondary, but you know, the most important thing for differentiating is to make sure there's an outflow obstruction, so something blocking the period. So we should really see normal anatomy, and I'll talk about the interpretation for this young lady here. But when we're talking about kind of female athletes or people with disordered eating, it can be really challenging to make that diagnosis based on laboratory data, which then thereby makes it somewhat more challenging to have that conversation about what to do and how to manage this. So you may see hypogonadic tropic hypogonadism, so things may all be suppressed, FSH, LH suppressed, estradiol suppressed, which you know, depending on the circumstances, you may need to do evaluation of the brain, or probably more commonly, they're somewhere in between, you know, where maybe the FSH and LH are normal, estradiol is like borderline normal. And the thing that's challenging about it, right, is GnRH is a pulsatile, is happening in a pulsatile manner. So I always say that these lab results are what was happening the day that you had them drawn. And that can be really challenging for athletes too, who may go in and out of being more active or less active. But we'll say for this young lady, the ultrasound showed normal anatomy and a peripuberal uterus, so not quite the size that we would expect. And although her hymen and vagina appear normal, she's still at about 10 or 3. So here, of course, we're talking about something that has previously been termed the female athlete triad, which the terminology has changed a little bit, which we'll talk about on the next slide. And it's basically this triad, right, of energy availability, bone health, and menstrual status. And so kind of thinking through that spectrum, which I talk about so frequently about, you know, energy in for energy out, right? And we want to eat healthy, but sometimes it becomes unhealthy, or we want to exercise to be healthy, and then sometimes it becomes unhealthy. So this up here is really kind of, is this disordered eating? Is also a big part of this. And then kind of, I find, especially for the athletes, it's really important to talk about bone health, cardiovascular health, right? Because this is what's going to allow them to be successful athletes. And that finally, this is all impacting the menstrual status. And so when I see them, it's usually because they're not getting periods, and it's taking a long time for them to come back. And we kind of have to like reframe and reshift to, you know, what is the underlying cause again? And so a better name for this is relative energy deficiency, because of course, this triad exists for people who may not necessarily have an eating disorder, but perhaps they have a GI condition and they're underweight, right? So this is the same situation. It's just a little bit of a different scenario, but same triad. And I like this picture because it really shows how on a spectrum this is. And so you might find, like, even if, you know, if I have somebody with an eating disordered eating, they might get to that normal weight, but it still may take a long time for them to get their periods back, like 6 to 12 months, because they may go in and out of that healthy balance. And it's a really hard thing to give a specific point, which is not my expertise and why I truly lean on, of course, the specialists in disordered eating. But I think this picture is a great description of this. And then again, kind of, I think in the adolescents, it's especially in the athletes, kind of talking about how much this can impact other things. So REDS is meant to be relative energy deficiency sport. So for the athletes, that it could it's not just about, certainly not just about getting a period, but it could impact, muscle strength, endurance, increased injury and stuff like that. And that is sometimes something that, we kind of have to like break through and make the connection to get people on board with making some changes. And so these can be very challenging, as I said, and it's not my primary expertise, but I imagine that most people on this call today have seen somebody on the spectrum here of this. And so really leaning on our colleagues in dietitian or nutrition that have some type of expertise in athletes or disordered eating. And I just, never hesitate to send somebody to an eating disorder treatment center. It's sometimes hard to broach that topic with the parents and the family, but got to do it, right? And then, of course, making sure there's sufficient calcium and vitamin D, considering Odexia in severe cases. And then I think what is really important from my perspective as a gynecologist is that birth control pills are really controversial, right? So this goes back to the idea of why is this happening and what do we do about it, right? So I think, in a lot of scenarios in OBGYN, OCPs are like a Band-Aid, right? So yes, we can give you birth control pills, your periods will come every single month, but have we gotten to the underlying cause here, which is you need to have, there's, insufficient nutrition, maybe there's some sort of disordered eating happening, and then we're never going to know, it's going to mask that recovery, and we're never going to know, did the periods kind of come back on their own? And then we know you've reached that kind of recovery state, and oh yes, you need birth control, we can take care of that. And then, of course, like any form of hormone replacement specifically, such as like hormone patches or something, would be for pretty severe cases of disordered eating. So I'm going to shift gears a little bit. And again, feel free to chat anything if anyone has questions along the way. But I'm going to shift gears a little bit to talk a little bit more about the treatment, as far as like what are birth control pills and what are other options for menstrual manipulation and how that might touch on your practice in your subspecialty. This is somebody at the Women's March actually from a couple of years ago. So the message is that OCPs are relatively safe in young, healthy people, right? And I guess a lot of the times at PSV, we're not taking care of all the healthy people, but they're definitely young. And so the contraindications this can be in some ways somewhat short, right? So the risk is really pertaining to the combination OCPs that contain estrogen. But the progesterone only option or the progesterone only pill is very, very low risk, and as are some other progesterone only options that we'll talk about. But the biggest risk, of course, is that history of clotting disorders. And other things that often come up are that of migraine with aura or any type of focal neurological deficit, and then any other type of hypertension or vascular disease. So we're talking about the mechanism of action. I hope you're not tired of this, my very favorite photos here. But there's multiple mechanisms of action about how birth control pills work to achieve like contraception, right? So truly by suppressing ovulation here, decreasing that GnRH pulsatility, suppressing LH-FSH, and basically inhibiting ovulation, that LH surge. But the thing that I use it most frequently for in adolescents, right, is that endometrial atrophy. So really like thinning out the lining and making the periods go away, right? Or managing the periods. Certainly lots of advantages in this age group, depending on what's going on. They are effective if that's the only downside, right? For this age group specifically, is they're effective if you take them properly, but they're pretty safe. They're reversible, immediately reversible, and there's usually minimal side effects. Really can help with painful periods, endometriosis, heavy periods, anemia, PMS or mood changes symptoms. So a lot of people with premenstrual dysphoric disorder or some variant of that, those anovulatory bleeding, and can also prevent ovarian cysts for those who have had that in the past. And then we know long-term that there's decreased risk of ovarian endometrial cancer, decreased acne, hirsutism, or slowing of the hair growth a little bit, endometriosis pain, and benign breast disease. The one thing that I didn't put on here that's always like a teeny question mark, of course, is breast cancer, which comes up a lot. And certainly in teenagers, the breast cancer risk is almost zero. What I don't think we totally understand is what is the breast cancer risk after like 30 or 40 years on them. The thought is that if there is a microscopic tumor that on birth control pills, it may grow to become clinically noticeable, and that is maybe the mechanism of action, but I don't know that there has been any solid study to give us like good numbers about that, but it comes up a lot because I see a lot of families who the mom has had breast cancer. So it's an important one that we need to be talking about. Combination OCPs, again, back to the risks, right? So venous thromboembolism is really the biggest one that we always talk about. It's like the number one that comes up when I'm counseling somebody who's starting them. But it is overall low in young, healthy people, right? So 30s, 40s, maybe a different story with the estrogen. Hypertension is pretty rare that they would be primarily caused by OCPs. Certainly if they already have hypertension, we should be talking about another option. But I have had a couple over the years, and then stopping it usually comes back to normal. I have had one kid who had cholestatic jaundice here on OCPs, which it's like something that you only read about in the textbooks, but now I have to include it here because she truly had it. But then reversed, of course, off of the pills and stopped it. Hepatic neoplasms have also been described, of course, and if they are primarily related to OCPs, are reversible. If they weren't necessarily caused by the OCPs that are there, is a contraindication of taking them, but may not be reversible in that case. I love this slide because it kind of takes us back to historically where birth control pills were, which was 50 micrograms or more of ethinyl estradiol, and seeing that now we know they can be effective at much lower doses. And so that really has lowered the risk of venous thromboembolism. And then truly looking at the risk of VTE in pregnancy is certainly much, much higher than exposure to OCPs. So I always think that's an important thing to remember. What is in them? It often does feel quite mysterious, doesn't it? But they all have the same type of estrogen. It's just at different doses. And most of them are all 20 and 30 microgram doses. And then what's different about them is the type of progesterone that's in them. And so most pills have a first or a third generation progestin. And I do kind of tailor them for certain people. The second generation progestins, that's what's in the IUD, and in one birth control pill called Seasonique, which is one that some people use, but it is slightly more androgenic. And then more commonly, the least androgenic ones are the ones that we use often for PCOS or girls with acne. And then the fourth generation drospirenone, that's what's in Yaz, which I tend to use just slightly less because there's a slightly higher risk of VTE because there are anti-androgenic, because of the diuretic properties of that medication. But some people still use them, and that's okay. I put this together because I do a lot of like tinkering with pills and doses and types of progestins for people, but there's really not a perfect answer. And I think, especially as we're learning about the genetics of metabolism and pharmacology, some people may react different ways to pills that doesn't meet what we see in the literature, right? So although I do this and try to tinker with pills, then it can get confusing, right? So you need more estrogen, no, you need less. No, wait, this is the wrong pill. So sometimes you just kind of switch it up and see what happens too. And then lastly, I wanted to touch on a little bit about menstrual manipulation because, I certainly get a lot of referrals from neurology and developmental and psychiatry for consideration of menstrual manipulation. So that is something that I do quite a bit of for lots of different reasons. And this is like one of my favorite mantras in life, but also about menstrual manipulation, which is setting your expectations to what is achievable. Nothing is perfect, right? So there's lots of different options. Of course, like all the different options of birth control are things that we can use to manipulate the periods or stop the periods in what I call optimal menstrual suppression, meaning that we're trying to stop the periods, but nothing's perfect. So we're going to optimize our ability to do that. And so combination pills can be used certainly like any pill. And if you want to be prescribing pills, there's no right or wrong pill. It's you kind of just choose one and can go with it. But they can be used continuously, extended use. Of course, the big concern is with any immobility, estrogen contraceptives remain a little bit controversial. So you certainly don't right? Like do no harm. We don't want to cause a VTE in somebody who's wheelchair bound, but something to be talking about. Oral progestins in higher doses. I've been using that more and more over the years for people who really need to like acutely stop the periods, don't have time to kind of tinker with birth control pills. And also for people with endometriosis or pelvic pain. And that can be tapered up, and I'll talk a little bit more about that. And then there's the Depo-Provera, which actually works really well. And I have a lot of families who choose that for kids who can't swallow pills. Maybe they don't want to go under anesthesia for an IUD, and that the Depo tends to work really well for achieving amenorrhea. And then of course the IUD, my very favorite, can result in amenorrhea for most teens over time. But of course in some individuals that require sedation. The key is that menstrual suppression is really not recommended before menarche, because we don't want to impact, all those hormones that they are exposed to leading up to menarche are really healthy, certainly for development overall and health. So there are so many different types of birth control pills. This is just a small smattering. There are like hundreds. And so I figured I would just kind of point out some of them so you can know what on earth they are. If somebody's like, oh yeah, I'm taking this. So so most of them come in this, where the end is cut off here, where it's just 3 weeks, monophasic pill, same dose every single day. And the last week is, the placebos, right? So that's probably the most common, where there's a 7-day placebo. Then there's like the ones where there's a shorter placebo week, which is only 4 days, which in truth is probably all that people need. It's just that historically, when birth control pills were created, they were like, oh yeah, 7-day period. People should have a 7-day period. But it doesn't, here's a 4-day pill pack. This is the Seasonique, which is an extended pill pack, meaning that you get a period every season. So some people like to use that. And then this is a triphasic pill. So meaning that the dose changes every week. And again, that was when these were initially created historically, where they're trying to like mimic the normal menstrual cycle, which of course taking birth control pills is not natural as far as hormones go. So what I've seen is that sometimes with the triphasics, there can be irregular bleeding in between those doses. So we really tend to use monophasics, and there are many fewer triphasics on the market now. The progestins, so there is a progesterone only pill here. This is one that's been around for ages and ages. I mean, it's probably one of the lowest risk medications that I prescribe. There is one other newer progestin only pill called Slind, which is actually just a high dose of drospirenone. Most insurances are not approving it, but the thing about that particular pill is that it's more effective as a contraceptive. But this one nevertheless can work well for some people. It's a very low dose, but it can work really well to take away periods for some. Similar to norethindrone is norethindrone acetate. So this comes in a pill bottle. And what's nice about this is that you can really titrate it up. And this is what I've been using, not just me, but in our specialty, I've been using more and more to achieve menstrual suppression. There's always a lot of talk about that there is some peripheral conversion to ethinyl estradiol. And the reports have been a little bit variable about how much conversion there is. And certainly the clinical significance of it is not quite clear. But I do certainly have pause. If somebody has like an active history of a clotting disorder, it's probably not something I would use, right? Again, like Depo-Provera can work really well as well. About 90% will achieve amenorrhea by the 4th dose. Sometimes when we're using it for suppression, we'll kind of do it instead of at 12 weeks, do it 8 to 10 weeks until suppression's achieved and then can space it out. The biggest painful part of it is having to have that three-month administration. So certainly I've worked with like pediatricians in different ways for girls to be able to get this. There is a subcutaneous version that can be given at home, but most people don't want it. And then of course, because it's progesterone only, there's a lower risk of VTE. So I have a lot of families with girls who are immobilized or in wheelchairs that use this. There is still a black box warning on Depo-Provera about decreased bone mineral density. We do know that there's adequate recovery after discontinuation, but there are some women that use this for longer than the 2-year warning, right? And so the question is this clinically significant? Do we see increased fracture risk? And some studies have indicated that that's not the case, but really it's something that, have a conversation with them every year is like, well, what's the benefit here, risk benefit here? And sometimes like these families are so desperate, there's really nothing else to do. If they were having seizures every month with any cycles and vomiting in the ER. So I still use it past that 2-year mark. Of course, IUDs are really, really excellent. And I think this was one of the questions that was asked, is do I do them under sedation? And yes, definitely, frequently. So when I see somebody for menstrual suppression, I talk them through all the things from pills to IUDs. And I think it's just kind of weighing that, what the family is comfortable with, and what that risk is, right? So if it's a kid with autism, and the sedation perhaps is lower risk than somebody who has multiple medical complications, and going under anesthesia might be a bigger deal. But for the younger kids, of course, sedation is often required. There is irregular bleeding, can be common initially, but the amenorrhea rates are pretty good. And then what I typically use for this is going to be the Mirena, which gives a higher likelihood of amenorrhea, and is now actually FDA approved for 6 years, and some people are using it for 7. But for the menstrual suppression kids, it's really like, how long is it working? Even if it would be effective as a contraception, is it suppressing the periods? And then I did put the contraceptive implant in here because I do a lot of those for contraception or painful periods, but it's really not recommended as first-line treatment for menstrual suppression or manipulation of periods, just because there is a high incidence of unscheduled bleeding. It certainly helps with painful periods and is a good birth control, but only about 20% achieve amenorrhea. When it works great, but about 10% request removal, which is high. And then just a couple last slides here to touch on things that I know some of us likely have in common. I see a lot of probably the biggest medication interactions that I kind of have to work with or work around are those of anti-epileptic drugs. And there are still options. Nobody is thrown to the street, right? I mean, estrogen is thought to be a proconvulsant, but has not been associated with increased seizures. Irregular bleeding can be common. So a lot of the interactions will be that the anti-seizure medication will impact the amount of circulating hormones in the body. So there could be more likely to have breakthrough bleeding. What's a little bit more tricky is those who have the opposite, like where the hormones may impact the efficacy of the seizure medication, which that's kind of like a whole different story there. Or some of the mood stabilizer medications are also a concern. But that's something that we can like work with if necessary. And that really progesterone's increased seizure threshold and can really play an important role. Like I've definitely had kids who were in the ER vomiting, seizures, just like horrible with periods, and then started on Depo and just was like a life-changing for the families. And then for our surgical subspecialty colleagues, talking a little about combination pills and perioperative care. And, you know, and this is specific for the estrogen containing options, right? So thinking about that increased risk of venous thromboembolism postoperatively and postoperative mobility. And so there's, I mean, I don't know, I guess we could call it controversy on whether to stop or continue. I think it's obviously a risk benefit discussion. That's like the name of the game in our profession, right? Is if it's a major surgery, certainly I would not have somebody who's going to be immobilized for 6 weeks taking estrogen containing pills. But if they have endometriosis and they're going to be like in horrible pain, okay, so maybe we put you on the progesterone only pills, which I have definitely done for like 6 to 8 weeks. So maybe things aren't perfect, but you're not going to end up recovering from surgery and also being in severe pain, versus like a minor procedure, even like an ovarian cystectomy, probably don't need to stop the pills for long periods of time when like the next day they're going to be up and about and moving normally. But I just thought that would be another pertinent thing to share. The last thing I'll leave you with is for those of you who are most of you who take care of kids with complex medical conditions, there's a really, really great evidence-based resource that is from the CDC, and it's called the U.S. Medical Eligibility Criteria for Contraceptive Use. It is available for free online in like a PDF. There's also an app that's $10. But it's just really nice. And I like to pull it up for kids with medical conditions because I can show them, it's like a picture where you can see 1 to 4, right? 1, there's no restrictions. 2, benefit likely outweighs risk. 3 might be too risky. 4, absolutely not. And so this is just an example of, and it's stratified based on age. This is I's initiation versus continuing, which is different. And so this is, migraines, of course, are a common thing, but we treat a lot of people with migraines take birth control pills if they're unaffected with them, but that aura is a contraindication. Although I feel like there's some new data that's going to be coming up for that soon. And so this is just another example of some of the things that they talk about, rare anemias, breast disease, breast cancer here, an important one, breastfeeding, diabetes, of course, that's one that I pull up all the time to go over with families. Less commonly am I talking about gallbladder disease, but it's got a lot of different things in there. And so my parting gift is that about long-acting reversible contraception. I think for most kids who maybe have a medical condition that could preclude them from taking some type of other hormonal medication, that an IUD is actually fairly low risk. The biggest risk is of the procedure probably, but that as far as like a medication interaction, it's pretty rare. And that I'll leave you with my stuffed ovary and answer these questions here. So do you place all IUDs under anesthesia? Good question. Definitely not. I place most IUDs in the office. I have had 14-year-olds who I put IUDs in the office and they tolerated it just fine. I think it's really depending on like the indication, right? If there's a need for controlled circumstances, so if they have a rare platelet disorder, probably not somebody I'm going to be doing in the office. Or if they're like, I have done like a 10-year-old with Down syndrome, not an office appropriate. So those would be people that we would do under anesthesia. How long would you watch and wait with a patient who is having breakthrough bleeding before you change a pill or dosing? So in general, I usually say they want to try it for 3 months because sometimes it will stop. But I do find there are certain pills, like one of my very favorite pills, GINA, 20 microgram pill. There are some people that just have a ton of breakthrough bleeding on that pill. And so if they call me after a month and they're like, I've been bleeding the whole month, I'll probably switch that pill. But in general, about 3 months. What is the average time that the menstrual cycle will return after removing an IUD if the patient had amenorrhea? So this is such a great question because actually when an IUD is removed, there is most commonly a withdrawal bleed from it having been removed. So most people will get some type of period right after it's removed. But for some people, it may take some time to build that lining back up. So I don't know if I can give you a specific like number of months, but it may take a few months for the lining to build up again because it's been so thin for all that time. If we have a patient with clear PCOS by labs and exam, when should we refer to you versus endocrine? Also an excellent question. So I do have a clinic that I do with Rinku Mehra, termed our PCOS clinic. And we see these kids together. Of course, there's so much PCOS, it's probably would be difficult for us to see all of the PCOS patients in that clinic. And so but I do tend to think that it's helpful in the teen years for them to be seen by endocrine and GYN. And then usually by the time that it's kind of been sorted out as an adult, most of the kids don't require long-term endocrinology follow-up, and it's mostly managed by GYN unless it's like significantly complex. So, I mean, we see a lot of, I think we all see a lot of PCOS, but we're happy to see them in our multidisciplinary clinic. You mentioned there may be new data about using OCPs with migraine headaches with aura. When do you expect that data to come out? I don't know. It's actually just from a conversation that I was having. But I think that the idea is that, right, so the risk for those with migraines with aura is that for stroke. And I think, is that significant in certain populations like teenagers, right? Now, if you have somebody with migraines with aura and every day they start their new pack, they're getting a migraine with aura, well, then that's not going to be a good option for them. But I don't know that it'll be like everybody can have it, but I think that there might be some new data and language on that, and I'll try to find out more about that for you. What other multidisciplinary clinics do you participate? That's great. So with endocrine, PCOS, hopefully in the near-ish future, we'll have some more transgender care as well with endocrine. And then with Carly Varela in hematology, we do heavy menstrual bleeding clinic, which is once a month. And usually it's those kids that were admitted to the hospital with requiring blood transfusion or who have like a rare bleeding condition or family history. Any other questions?
All right, thank you so much, Dr. Casey. We always appreciate having physicians at our APP conference, so we appreciate your time. So our final speaker of the day is Ashley McCoy. Following her talk, please join us for an opportunity to network and ask any additional questions that you might have. So Ashley McCoy is a physician's assistant in the urology department and celebrated her 2-year anniversary with PSV in August. She received her bachelor's degree from Virginia Tech and her master's degree in physician assistant studies from Bethel University. Ashley's clinical roles include outpatient clinic at PSV, assisting in the OR at both Inova Fairfax and at PSV in our ambulatory care center, and as well as seeing hospital consults at Inova Fairfax. Welcome, Ashley.
Thanks so much, Akila. Thank you guys, everyone, for putting together this educational day too. It's been really great. Today, I'm going to talk about pediatric urinary tract infection. I am a physician assistant in the urology department, and I end up seeing a lot of these patients who have these recurrent UTIs or also other avoiding issues as well. It's a pretty broad topic, but we'll try to sort of just scrape the surface and cover the most important topics today. I don't have any disclosures or disclaimers. As far as our learning objectives for the day, we're going to focus on identifying the risk factors that predispose kids to developing these UTIs. Talk about understanding the diagnostic criteria for urinary tract infections, and then how to apply the diagnostic criteria to classify asymptomatic bacteriuria. We will describe the implications of febrile versus non-febrile infections, identify when antibiotic prophylaxis is indicated, and then, of course, understand when to refer children with UTIs as well. Urinary tract infections is something that I think is a pretty common office visit, especially for pediatricians. A lot of people think about urinary tract infections as a problem that pertains mostly to toilet-trained children, but the truth is that we actually see kids who can have these UTIs anywhere from a few hours of life all the way through to when they've sort of graduated our clinic and gone on to the adult urologist, of course. It's thought that pediatric UTIs make up about 1.75 million office visits per year, and they account for about $180 million spent annually. As far as the range in severity for UTIs, they can be anywhere from sort of just like a simple case of cystitis, where the urinary tract infection is just within the bladder, all the way through to pyelonephritis, which is a kidney infection with the potential of causing renal scarring, and then even long-term loss of renal function. And then, as with many areas of medicine, even in the field of pediatric urology, there's a lot of variations in how certain urology providers manage different conditions like recurrent UTIs and vesicoureteral reflux. As far as the incidence goes, we think that about 7% of children presenting with a fever in the first year of life are ultimately found to have a urinary tract infection as the source of that fever. We also know that about 3.5% of children will have a urinary tract infection per year. It's thought to be one of the most common bacterial infections in pediatrics. Generally, when you think of people who are having urinary tract infections, you definitely think of females. And it is certainly true that after the first year of life that we know that females are at a higher risk. However, actually during the first year of life, we know that males are twice as likely to sustain a UTI between birth and 4 months, and then that the incidence actually equalizes between 4 and 12 months. Something that you'll hear me talk about a lot today is bowel and bladder dysfunction. It's probably the #1 risk factor that we talk about in the clinic. It's how I spend most of my days counseling patients. It pertains to both those who are having febrile and non-febrile infections as well. Bowel and bladder dysfunction refers to the constellation of lower urinary tract symptoms and then also constipation. It is certainly possible that kids may be having, one or the other. They have some constipation but aren't having voiding issues, or vice versa. But more often than not, one precipitates the other. And so we usually tend to talk about both with kids, just to at least make sure that they're aware of the other one, even if they're only concerned about, voiding issues or constipation. It is quite common in children and can cause lots of different symptoms, anything from dysuria, recurrent UTIs, as well as sort of all of our other voiding symptoms too, such as like incontinence, urgency, frequency, things like that. The first part of bowel and bladder dysfunction is this urinary stasis. So anyone with kids or anyone who treats kids know that they tend to wait until the last minute to use the restroom. They're sort of chronic holders. Obviously, everything else in their life is much more important than going to the bathroom, and so they wait until the last minute to do it. When that urine is static within the bladder, that just gives the opportunity for bacteria to flourish and accumulate. I often talk about it like a puddle with families, that the longer that the urine is in the bladder and it's accumulating bacteria, that's sort of just like a puddle that's staying there with still water, and you see it, becoming like murkier and murkier with time. Of course, a lot of children also struggle with incomplete emptying, which can cause urinary stasis. The primary reason that we see kids struggle with incomplete emptying is usually from either constipation, which can sort of impact the squeeze of the bladder, or also voiding dysfunction, which is called pelvic floor dysfunction. And the way that I describe voiding dysfunction is sort of like if they're peeing against a closed door. So if it's for kids who aren't really able to fully relax their pelvic floor muscles that well and empty their bladders completely. And so some of that urine is staying in there and definitely contributes to that stasis then. Other underlying factors that can occasionally contribute to urinary stasis that we think about are like megaureters or hydronephrosis, or more importantly, vesico-ureteral reflux. But we'll talk about those just a little bit later. And then from a bowel side of things, constipation, it really matters because this refers to pressure that comes from, if the rectum and the colon are distended, they're putting a lot of backwards pressure on the bladder and really impacting the ability of the bladder to function properly, meaning that it, ability to squeeze and empty completely. And the other side of things is that kids who are chronically constipated, you can imagine that if they're having trouble sort of like emptying their bowels, they can often develop this voiding dysfunction. And then it's the same pelvic floor muscles that we really use to void and defecate. So if they're having trouble with one, then they're likely to have trouble with both. I find this picture really helpful. It really shows that, a lot of people struggle to see the relationship between the bladder and the bowel, but it really is such a close interrelationship. So the main thing, that we look at here is that there is quite a mass effect from any backup of stool in the rectum. It really presses on the back of that bladder, and you can see that it would cause, inability of the bladder to really squeeze properly or empty. And then, it's not necessarily pertinent to today, but it's definitely a conversation that we have, especially when kids are having urinary frequency or urgency, because you can see that the bladder is just not going to be able to fill up the way that we would expect that it should be able to. As far as other risk factors for urinary tract infections, we know that kids who have congenital anomalies of the kidneys and urinary tract are also at an increased risk for UTIs. The primary one that we worry about is vesico-ureteral reflux, which we will get into a little bit later. As far as kids who have hydronephrosis or megaureters, we really don't generally prophylax kids with hydronephrosis, even though that theoretically should contribute to urinary stasis. We just anecdotally don't see them coming in with recurrent UTIs. And as far as prophylaxing kids with a megaureter, it really just sort of depends between urologists whether they feel that they need prophylaxis. Certainly, kids who have had a previous urinary tract infection are at risk for having another urinary tract infection. And we know that about 8% of kids will have a recurrence, and of those who have a recurrence, 3/4 of those will happen within the year. The truth is that it's likely due to underlying factors, most likely bowel and bladder dysfunction, that can take quite a bit of time to resolve, and is really a setup for kids to have recurrent infections until they're sort of on the other side of things. Of course, sexual activity in adolescents and adults can be a risk factor as well. A lot of times we're seeing kids who are much younger than this, but if I do have sort of like an older teenage girl, it's always helpful to mention, proper hygiene to make sure that they're voiding after intercourse and not, risking getting a urinary tract infection. And then certainly urinary instrumentation as well. It's a pretty low risk category, but it is a risk. We think that catheterization causes urinary tract infections in about 1% of patients. Again, that's not that high. We certainly have our own subset of patients who are on chronic catheterization. We do not keep them on chronic prophylaxis, and they tend to do pretty well. And likewise, we don't routinely prophylax patients who are having catheterization, whether it's for urine testing or BCG either. As far as other risk factors, there are quite a few. The female sex is also a risk factor just because the length of the female urethra is much shorter than that of the male. And so the bacteria from the perineum can sort of get into the bladder pretty quickly. And then, of course, the close proximity of everything for a female is much different than that of a male. In a boy, though, it is really important to talk about circumcision status. And that's because circumcision reduces the risk of UTIs by 85% in the first year of life. Now, obviously, this talk is about recurrent UTIs. So if you have a patient with recurrent UTIs who's uncircumcised, that would certainly be a consideration is to recommend circumcision to decrease that risk. But in a boy who's not having UTIs, we agree with the AAP stance that circumcision is really a personal preference and that we don't recommend for or against it. And the other thing is that after 1 year of life, the risk of sustaining a UTI is actually equal amongst circumcised and uncircumcised boys, assuming that they don't have underlying issues like reflux, in which that risk of UTI can actually, that it is higher for uncircumcised boys even past the first year of life. So that would be a population that we would certainly recommend circumcision for. If you have a patient in whom you think that they would benefit from circumcision or whom you think would benefit, but family really feels strongly about not doing so, then they should we should, at a minimum, we would recommend treating their phimosis if they have that. Phimosis is just where in an uncircumcised boy where the foreskin's really tight and not able to be retracted fully to expose the glands of the penis, and it is an increased risk for UTI. There are newer studies now showing that they actually showing decreased rates of recurrent UTIs in uncircumcised boys after using steroid ointment to treat their phimosis. So if we have a patient in clinic, and this is certainly something that could be, that could be done in the primary care setting, if the foreskin's very tight, we use betamethasone 0.05% ointment or triamcinolone 0.1% ointment. And I often like to really show families how to put on the ointment. Ideally, they would retract the foreskin sort of as far back as it's willing to go without sort of like forcefully retracting it, and then putting the ointment around the most narrow portion of the foreskin twice a day up to 2 months. And a lot of times that helps that foreskin sort of loosen so that they're able to pull it back, which is helpful so that, in a toilet trained kid, they can do that while they're voiding. And then also anybody, after they use the steroid ointment, it's really important to emphasize to families that they should continue practicing regular retraction at least once a day in the bath or shower, just so they can clean underneath with some water. And then, because we don't want the foreskin to become really tight again. And if they don't practice regular retraction, then that can certainly happen. And if it does become tight again, it's not always as responsive to steroid ointment the second time. It can be a problem. As far as the signs and symptoms of infection go, they can be really nonspecific in kids. These nonspecific symptoms are things like urgency and frequency, where kids will say that they feel the urge to go to the bathroom pretty soon after they've just left. And then when they get there, it's really small volume output of urine, or no urine's coming out. But as soon as they leave, they feel like they have to go back. Kids can also have increased urinary incontinence. Now, urgency, frequency, and incontinence are extremely common symptoms that we see in clinic. And I can tell you that I don't generally test their urine because infection is usually the last thing on my mind for those kids. Really, to be concerned about a urinary tract infection, they would need to be also complaining about either pain or having a fever. So those are kind of the hallmark symptoms of UTI. Certainly hematuria is also a symptom as well. In a kid who is not toilet trained, obviously dysuria is really hard to assess. And so generally these kids only present with a fever. And technically a fever is considered anything over 100.4, but more often than not, it tends to be closer to the 102, 103, 104 range, and these kids are pretty sick. The fever is actually what differentiates cystitis from pyelonephritis. Technically, a DMSA is the only way that you can truly diagnose pyelonephritis, but we don't just get DMSAs on every patient who's having a febrile infection. If they have a positive urine test and they're febrile, it's considered an upper tract infection unless proven otherwise. And it's also important to remember that every single upper tract infection that a patient sustains has the potential to cause renal scarring. So we take each of them pretty seriously. Something I really did want to highlight is that malodorous and cloudy urine are symptoms of concentrated urine, but not necessarily of infection. So I have lots of families coming to me and they say, you know, my daughter, she had a UTI, her urine smelled really badly, and then they treated her, the smell went away, and then the second we finished treatment, the smell came back. But the whole time the daughter's sort of like not having any other symptoms, they're not having any pain, they're not having any fever. In general, in those kids, I really don't recommend urine testing. By us testing their urine and kind of repeatedly treating them, it tends to lead to the overtreatment of something called asymptomatic bacteriuria, which we'll talk about a little bit later. The better thing to do is to really treat why their urine is so concentrated. So it may be concentrated because they're not drinking enough, and so I'd often recommend increasing their fluids. And it often could be concentrated because they're not emptying well, perhaps due to constipation, or not relaxing their floor, you know, not taking their time in the bathroom and things like that. So focusing on constipation and increased hydration would really be the better things to recommend in a kid who's really just having foul odor, you know, foul odor with their urine or cloudy urine. As far as the physical exam goes, certainly we are seeing a lot of these patients now over telemedicine, and so it's not always possible to get a good physical exam. But if the patient is sitting right in front of you in the office, it's important to especially focus in on a few things. Of course, we always do an abdominal exam. A lot of times in kids, you can palpate any stool that's in the belly. And then we always like to look at their back as well, looking for any concerns for underlying neurological etiologies. So if they have like a sacral dimple or things like that, just because a kid has a sacral dimple, I don't automatically refer to, you know, to neurosurgery, because it is a pretty common finding that doesn't usually carry any sort of problems. But I always mention it that they should talk to their pediatrician about whether it warrants referral or additional imaging. And then, you know, of course, we do a genital urinary exam. In girls, there's sort of two things that we're really looking into. The first thing is whether they have any labial adhesions. Now, labial adhesions are really common in a lot of prepubertal girls, and we don't actually treat them generally unless they're having problems. So if they're not having any sort of post-void dribbling or leakage, if they're not having urine trapping and UTIs or pain, then there's really no reason to sort of treat the labial adhesions. They will go away with time, primarily by puberty if they haven't before then. But if a patient has pretty significant adhesions to the point where it could be causing urine trapping and maybe a risk factor for infections, then it would be worthwhile treating the adhesions. We treat them the same way that we treat phimosis. So we use betamethasone 0.05% ointment. They can apply it to the adhesions twice a day for up to 2 months. Some people also use Premarin as well. That's another option for treating labial adhesions. And then the other thing we look for is any urine pooling in the vagina. So there's two different reasons that females can have urine pooling. One of them is called vaginal voiding, and it's just that a lot of little girls sit with their legs really tight together on the toilet, and a lot of the urine collects there and actually refluxes back into the vagina and then dribbles out later. It's important to kind of go over posture with them so that when they're sitting on the toilet, occasionally we'll recommend that they sit backwards, or at least at a minimum they sit on the toilet with their knees pretty spread apart to make sure none of the urine is getting trapped. And then much less likely, occasionally there can be urine pooling from underlying anatomic issues like an ectopic ureter. More often than not, the symptoms that a patient has an ectopic ureter is actually that they have continuous leakage. It's ongoing all the time. They're never dry, rather than recurrent UTIs. When it comes to the genital urinary exam for a boy, again, we want to look for phimosis and then assess their circumcision status. I also find that this is a really good time to talk about proper hygiene for boys, specifically if they are uncircumcised. I have a lot of families come to me and say, you know, I didn't really know how to like take care of it. So you kind of have to educate them about practicing regular retraction in the bath or shower. And then I always like to emphasize to families that if they are retracting the forcing for any reason, they always need to sort of like push it back forward to cover the glands again to prevent paraphimosis. A lot of families don't actually know that, and it you know, has the potential to cause a problem. And so it's something really important to emphasize with them. As far as urine collection goes, it is really important how we obtain our urine for the urine samples. In a child who is toilet trained, a midstream collection is fine, but I would go over with families exactly how that's obtained. You know that they really need to have, it needs to be a midstream collection. And then the other thing is that in a child who's not toilet trained, ideally a catheterized specimen is obtained. If you don't feel comfortable, or if parents don't feel comfortable, you could always start with a bag specimen. But if the specimen is positive, then you do have to go on to get a catheterized specimen, because there is a really high rate of false positives with bag specimens. It's reported to be up to 88%. So it's really only helpful if it's negative. As far as the diagnostic criteria, this is pretty important as well. Not anybody who grows bacteria on their culture is technically, diagnosed with a UTI. So we'll talk about that a little bit. It is really important that if a dipstick urinalysis is concerning for infection, then culture should always be sent, because it's really important to figure out, how many colony forming units they have of a certain bacteria, and also what the sensitivities are to make sure they're being treated properly. A positive urine sample means that they have evidence of infection on the UA, and so that means they either have presence of leukocyte esterase or white blood cells visualized on microscopy, and or they have positive nitrites on the UA. And then after the culture comes back, they should have at least 50,000 colony forming units of a single organism present on their culture. If they have less than 50,000 colony forming units present on the culture, or if multiple bacteria morphotypes are present, this is more suggestive of contamination rather than a true UTI. And if the child's culture is not really consistent with the above criteria, then it is important to consider other etiologies for the symptoms, especially if they're presenting with fever. Certainly there are exceptions to the rule. So if they really seem like they're having, a UTI and it's 25 to 50,000, you can sort of like use your judgment. But generally speaking, we really do abide by the idea that anything less than 50 is not consistent with a true UTI and more likely contamination. Again, we recommend against urine testing just for the purpose of identifying an infection in a patient who is not having symptoms. To be diagnosed with a UTI, the patient should actually be both symptomatic and have a true UTI demonstrated with both the UA and the culture. If a patient just has a positive culture but they're not having symptoms, they don't require treatment because they're not becoming sick from the bacteria that's found. And it also, you always have to worry about contamination in that situation if they're not symptomatic as well. And then lastly, we talked about this previously. While pyelonephritis can only be confirmed or diagnosed with a DMSA scan, if a patient has both a fever and a positive culture, then they should be presumed to have an upper tract infection unless proven otherwise. As far as the microbiology and what organisms we expect to see on culture, the most common is E. coli. I really like to mention this to parents because a lot of times they get really nervous when they see that they had an E. coli infection and they mention, well, it must have been the way that they were wiping. So a lot of parents just assume that it means that somehow stool was getting into the bladder. And I like to clarify that just because it was, that E. coli was present, that is the most common and not necessarily indicative of their wiping techniques. And then other organisms that we see sometimes include Klebsiella, Proteus, Enterococcus, Pseudomonas, and Enterobacter. The truth is that the bacteria that's present in the culture doesn't really change our management. And so while it's good to see the amount of bacteria that's present, it's less important to see what type of bacteria it was. Asymptomatic bacteriuria. So I've mentioned this a few times and it's really important to go over. We do see a subset of the population who are just chronically colonized with bacteria in their urine, but they're really not getting sick from the bacteria. And so more often than not, we don't like to do anything about it and they don't need anything done about it. What this means is that basically anytime a urine culture is obtained from these patients, it will look like infection, even if they are never having any symptoms at all. Because they're not symptomatic or having any issues with the infection, there's no reason to be treating their symptoms, unless their symptom is, of course, fever. Then that would be a bigger concern. But if they're not having symptoms, they don't need to be treated at all. As far as people who we know who suffer from asymptomatic bacteriuria, certainly our population who practices clean intermittent catheterization are known to be colonized because they're regularly introducing bacteria into the bladder with the catheter. But we also see this in otherwise healthy individuals, and they don't need further workup to look for underlying pathology just because there is concern for asymptomatic bacteriuria. It is kind of difficult in our patients who are on clean intermittent catheterization to diagnose pyelonephritis with them because sometimes they present with a fever, and we know that if their urine's tested, it's always going to look like infection, even if the fever could be coming from another source. the best way to differentiate pyelonephritis in a child who is coming in with fever and who is known to be colonized is to obtain a procalcitonin level, and a level greater than 1 is suggestive of pyelonephritis as the source of the child's fever. The only thing about procalcitonin is that it tends to drop pretty quickly, and so it tends to drop pretty rapidly after treatment is started, so it's important to go ahead and get that measured pretty soon. As far as the imaging and workup go, none of the imaging really needs to be done in the acute setting. It doesn't really change the urgent management, will more likely just change long-term management for these patients. It is a different workup whether we're talking about patients with febrile infections and non-febrile infections, just because with febrile infections, we're much more worried about underlying anatomic factors that are causing the fever, and we're really not worried about that as much in patients who are having non-febrile UTIs. Both anyone who's having a urinary tract infection, whether it's febrile or non-febrile, should have a renal bladder sonogram though. Things that we're looking for on the sonogram are looking for any hydronephrosis, ureterectasis. We're looking for any renal size asymmetry, making sure that there's normal echogenicity within the kidneys. We want to check and make sure the bladder wall doesn't look too thick, specifically if the bladder is distended. And then also if they're toilet trained and are able to comply, we want to get a PVR to make sure that they're actually emptying their bladder when they go to the bathroom as well. As far as additional workup for a febrile infection, this really does differ a lot urologist to urologist, and so we'll talk about sort of the different approach managements, but generally speaking, I would recommend referring any patient who's having a febrile UTI so that we can sort of, depending on who's seeing them, determine the next step for them. Some urologists practice the top-down approach when it comes to managing febrile infections, and what that means is that they would actually start with this DMSA scan, and the DMSA scan is a test that we get that looks for the renal function differential between the two kidneys, and also looks for any scarring or acute episodes of pyelonephritis. The way that the test is conducted is that the child just gets an IV and they're given a radiotracer that's taken up by the kidneys. It is really helpful to know whether there's any scars that they have sustained from the UTI, because not every febrile UTI will sustain a scar, although they all have the potential to. And it's also really important to make sure that if a kidney is scarred, is it functioning, 50-50? Is it functioning as equally as it should its counterpart, or is the other side making up more function to cover up for that side? Then if a DMSA scan is abnormal, then they would go ahead and proceed with a VCUG. But theoretically, if their DMSA scan is normal, meaning that they have equal renal function differential and there aren't any scars, there's really no reason to go getting the test of the VCUG to look for reflux. Other urologist preferences to practice the bottom-up approach, where they would get the VCUG first. The voiding cystourethrogram is a test that we get to look for underlying vesicoureteral reflux. It does involve a catheter, so the child, a small catheter is placed and contrast dye is instilled into the bladder, and then serial images are taken during filling and while the child is voiding to look for any reflux of urine. If the child does have reflux, then depending on how many infections they've had or what age they are, it may be important to get a DMSA scan afterwards, but that's again sort of up to the urologist at that point and kind of depending on their practice approach. I did just want to mention a couple of things about the VCG. It is important if one's being ordered that this refers to the fluoroscopic study and not the nuclear cystogram. The nuclear cystogram is a little bit more sensitive, but the fluoroscopic study is a much better study as far as showing us a better picture of the child's anatomy. And that it's important that if a child is having a VCG, they should be afebrile for 48 hours first. And because the VCG does involve catheterization in our older population, they may require general anesthesia for placement of the catheter as well. The only other thing is that for patients who are having non-febrile infections, we would recommend obtaining a KUB to look at the stool burden. As far as why we don't get that for febrile infections, in a patient who's having a VCG, their initial scout image will actually can be used in lieu of a KUB, and so they don't need both. So we talked a lot about it, and honestly, vesicoureteral reflux could be its own 1-hour talk. So we'll just kind of scrape the surface, but I would be remiss if I didn't talk about it a little bit. It's important because the UR is found in 30 to 40% of pediatric patients who present with febrile UTI. Vesicoureteral reflux refers to the urine refluxing backwards from the bladder towards the kidney, and it can happen while the bladder is filling or while the child is voiding, or sometimes during both. We grade it on a scale from 1 through 5, and the grade not only indicates the severity of the reflux, but also the likelihood of resolution. As I mentioned before, the primary mode of testing for VUR is with a contrast voiding cystourethrogram. Other options include that nuclear medicine cystogram, which we could use in follow-up studies. Or there's also a newer test that's come out now called the voiding urosonogram. It's not readily available. I know that Children's is doing it, but not a lot of hospitals are. The advantage of the voiding urosonogram is that it precludes the need for radiation. It is important to note that regardless of which study of the 3 that I just mentioned that you pick, they all require catheterization, so there's sort of no way around that. As far as management of VUR, it really, it can depend on a lot of different factors, such as how old the child is, whether they've had previous infections, what grade the reflux is, and things like that. If we are detecting reflux in a newborn baby and we noted it because of prenatal hydronephrosis, then typically all we do is put them on continuous antibiotic prophylaxis and repeat the study in 18 months to look for resolution or improvement. But again, sometimes once they're sort of reaching toilet training age, then what we may consider is actually just stopping the prophylaxis and working on urotherapy, meaning working on their bowel and bladder habits to maintain proper emptying and prevent constipation, and that sometimes is enough as well to prevent any infections, even with persistent VUR. It's important to note that a lot of children do outgrow VUR, but just because they don't doesn't mean that they actually require surgical intervention, as many of them, like I said, can stay infection-free just by practicing good bowel and bladder habits. Some kids do require repair for VUR. Reasons that we would proceed with surgical intervention would be if the child's having breakthrough infections on their continuous antibiotic prophylaxis, or if we've tried to pull them off of the prophylaxis a couple of times and they just can't seem to stay infection-free without it, or maybe in a case of a very high-grade reflux in which we're very worried that they're very likely to have more infections. And then again, I mentioned it before, we often recommend circumcisions for boys with VUR because uncircumcised boys remain at a higher risk of UTI even after the age of 1. As far as acute treatment considerations go, any child who's presenting with the UTI should be treated for at least 7 days, with an antibiotic. It is important to note that a patient with a presumed upper tract infection should not be treated with nitrofurantoin, as the drug has really poor tissue penetration in the kidney and is not an effective drug for an upper tract infection. As far as other medications that can be used, we really don't feel strongly one way or the other towards anything specific. Options could include Bactrim, Keflex, nitrofurantoin, again, assuming it's not an upper tract infection. If they do have a more complicated case of cystitis, meaning that they've had a recent hospitalization or infection, or if they have recurrent infections or have another genitourinary anomaly, then you could consider things like Ceftonir or Cefepime for their treatment. As far as when and what to use for preventative prophylaxis or for preventative antibiotics, we would consider prophylaxis in patients who are having febrile urinary tract infections, again, to decrease that risk of additional febrile infections, which could cause renal scarring, and or those diagnosed with VUR. This is something that certainly we're happy to decide. So if you have a patient who sustains a febrile infection, it never hurts to sort of start them on prophylaxis while they're waiting to see us, and then we can decide if they need to stay on it or not, depending on what else is going on. We also can use it in our patient population who are having non-febrile infections as well. We would use it in kids who have had more than 3 true UTIs in 6 months or more than 4 in a year. And the reason that we use it is because oftentimes these kids have really sort of created a setup for more infections, and it really helps to give the bladder time to relax and just stay infection-free for some period of time. Oftentimes we do prophylaxis at a minimum for 6 months, and then we can sort of trial coming off of it. And the most important thing is that within those 6 months is when we really focus on the preventative therapies. So working on their bowel and bladder habits to make sure that they're getting rid of these risk factors, which could place them at risk for more UTIs. I will say that this tends to work pretty well for kids. I haven't had a lot of kids who have come off of that 6-month therapy and needed to go back on it. Most of them have sort of made the changes that they needed to and are doing pretty well. But I always like to emphasize with parents to sort of hang in there. The changes are not overnight changes, they're habits, so they take time to sort of really work on, which is why we recommend 6 months. As far as which medications to use for prophylaxis, in a baby who's just born, our first choice is usually amoxicillin. If the baby does have any sort of resistance or has any sort of breakthrough infection to the amoxicillin, then they could be switched to Keflex. And then once they're 2 months corrected age, then we do graduate them to either Bactrim or nitrofurantoin. Typically in a younger kid, we like to use Bactrim because it's a little bit easier to dose in our younger patients. They tolerate the suspension really well, so you can sort of just dose it based on their weight, and they tend to do, really well. Nitrofurantoin is a little bit different. The suspension, it exists, but most kids don't tolerate it well. It seems that they often have a gag reflex towards it, and parents have a lot of trouble getting it down. And so the only other option that we use for nitrofurantoin is they make a capsule, which sometimes we can split in half. And so at a minimum, they need to at least be able to tolerate 12.5 milligrams, because the smallest capsule is a 25 milligram capsule. And for those kids, what we'll have them do is just have the 25 milligram capsule and break it in half and only sprinkle half of it each night for their prophylaxis. It is important to know that if a patient has a breakthrough infection on the prophylaxis, you really need to go ahead and look at the sensitivities. If the patient has a breakthrough infection and their infection was sensitive to their prophylaxis, it means that they might not be taking it, and it does raise concerns for compliance. And so then it's really just better to talk to families about barriers to compliance and what we can do to make sure that the child is getting the medication when they're supposed to. If the infection is resistant to their prophylaxis, which is what we would expect, then we would want to switch them likely to the other medication that they were not using. But you do want to make sure that, of course, that the infection would have been sensitive to that medication as well and would not have been resistant to it. As far as preventive treatment considerations, this is really the biggest thing that we talk about, and we spend a lot of time really counseling families on how to prevent urinary tract infections. It matters to both febrile and non-febrile infections. Even in patients who have BUR, we know that if they have underlying BVD, they're actually at a higher risk for failure from their surgeries if it's not well managed. So even in our kids who are extremely surgical, we have to sort of take it back to the basics and make sure that their voiding habits and their constipation are under control. When it comes to their voiding habits, we recommend timed voiding, and I like kids to go every 2 to 3 hours during the day. I tell them that this is how often a child should be emptying their bladder on a normal basis. Something that's really helpful in compliance is if, we talk about timed voiding watches. If you go on Amazon and you sort of just search for a potty watch or a time voiding watch, they come up with lots of different types, anything from something geared towards a 2-year-old with a toilet on it to something geared towards a 9-year-old that comes in lots of different colors that they can help to pick out. And what the watch does is you can set it so that it vibrates every 2 or 3 hours as a reminder for them to go to the bathroom. And it vibrates nice because it's not disruptive in class. And the watch is really great because it allows the child to take some responsibility for the problem as well. And it kind of takes parents nagging out of the equation, because it's not just mom and dad constantly reminding them. It sort of becomes a Simon Says game where we know that when the watch goes off, it means that they have to go try. And again, I do emphasize for the child with them in the room, I tell them that when the watch goes off, it's really important that they at least go try, even if they don't actually feel like they have to go. A lot of kids have sort of suppressed the urge to go, and they're used to holding it for so long that going every 2 hours, they won't feel like they actually have to go. But a lot of times once they get to the bathroom, they do find that they have, that they have urine output, of course. It also is really important to talk to kids about their voiding posture and taking their time in the bathroom. So it's really important that they're not rushing when they're in the bathroom, that they're taking the time to feel like they at least completely emptied their bladder. Ways to do this, sometimes we recommend double voiding, where they void and they go until they feel like they've emptied their bladder. We tell them to take a break, take 10 to 15 seconds and try to think about something else, and then try one more time to get any last bit out. Another way to do it is you could use like a sand timer as a reminder that they have to at least take a minute on the bathroom to try to empty their bladder completely, and then they can go. And then again, their voiding posture, so making sure that they're sitting, if they're a girl, that they've got their knees spread apart so that they're not having the vaginal voiding problem. And also that their feet are supported by a footstool so that they're able to relax those pelvic floor muscles appropriately as well. As far as from the poop side of things, you know, there are two different ways that we can sort of like assess for constipation aside from the history, which is of course very important, but sometimes a little bit difficult to elicit, especially once kids are in school and parents aren't really there and they're not seeing what's going on and kids aren't quite sure. A lot of times we'll have them do something called the corn test. And so I have them eat corn for dinner at night and they should see it in their poop the next day. I told them that if they don't see it the next day or if they see it the next 4 days, then it sounds like things are moving a little bit slowly and could benefit at least from, you know, from fiber supplementation at a minimum. And then the other thing is that if, you know, if they're really unsure of their stool burden, a KUB is always an option to obtain to see what the true stool burden is like on the inside. We don't like routinely, you know, order serial KUBs or anything like that, but it can be helpful to have that snapshot in time. As far as treatment of constipation goes, if they seem to be really backed up, then we might recommend that they start with a one-time clean out. So I put the doses here below. Basically, I tell them that when they're doing the clean out, they should do it on a Saturday morning when they don't have anything else going on the rest of the day. The child can start drinking the, you know, 32 or the 64 ounces of Gatorade or juice in the morning and finish sometime after lunch because it is quite a bit of volume for a young kid. After that, they should have quite a few bowel movements over the next 24 hours, and then they should start their maintenance therapy. As far as maintenance therapies go, Miralax, you know, is obviously really great and helpful, especially if the kid needs something a little bit stronger than just like fiber. I do emphasize to parents that it's really important that the kids are staying really well hydrated if they're on Miralax because they really, you know, they need that water to make sure that the Miralax is working well. And that's even true with fiber supplementation as well. One of our newest favorite things to offer to families is that they should get the adult fiber gummies. Kids tend to really like the gummies. It's very easy to sell them. There's sort of not compliance issues when it comes to that, but Benefiber is also a good option as well. And then certainly X-Lax is an option. Admittedly, I don't prescribe a lot of it or recommend it a lot just because I'm more comfortable with Miralax. So usually I tell parents that if the child has sort of like chronic constipation or if their constipation is refractory to Miralax, then it's really better that GI be involved because they're certainly the experts and can rule out any underlying issues. So this happens a lot. My patient has UTI symptoms, but their urine test is negative. So what do I do now? A lot of kids have UTI symptoms, primarily dysuria. Again, is our tip off to an infection. And then when we go to get a urine test, that's negative. Of course, these symptoms are often caused by the same things that can actually precipitate recurrent UTIs, meaning that this bowel and bladder dysfunction is certainly a risk factor for causing a lot of these symptoms. I kind of like to mention to families that if the child's a chronic holder, kind of like we talked about, and they have a very large bladder volume that they're trying to empty through the urethra, it's going to be uncomfortable. And that the easiest management is by actually just encouraging them to void more frequently and then having a subsequent lower volume of urine that they're voiding each time. And then again, any pressure from the rectum can also provide a little bit of discomfort as well and could be indicative of those symptoms. And so we would treat them the same way with the standard urotherapy. So making sure they're doing timed voiding and making sure they're preventing their constipation. And usually that's enough to sort of like help those symptoms go away. Certainly in a boy, it's always also important to consider things like phimosis and treating it with a steroid ointment if it's found. Or meatal stenosis. Meatal stenosis is something that we see only in circumcised boys, and certainly if the meatus becomes stenotic and they're having to sort of like really strain when they're voiding, then that could be painful as well. And we're happy to see those kids to talk about quick surgical repair. And then, of course, if urotherapy also fails to resolve their symptoms, they continue to have dysuria despite their time voiding and prevention of constipation, then we're happy to see those kids too. And finally, when to refer. So any patient with history of a febrile UTI, it's helpful for us to see them. There really is quite a bit of variation in how a single febrile UTI is managed, and there's so many factors that sort of can adjust how they're managed, how we work them up, and whether we prophylax them. So it's really helpful if they've just had any sort of febrile UTI that you just send them our way. And then, of course, patients who are having recurrent infections despite managing any adequate bowel and bladder management. So making sure that they're on time voiding and not constipated, but they're still having problems with recurrent infections. And then the most important thing is that when we are seeing these patients with history of UTIs, it's super helpful for us to see any previous UAs or urine cultures that were done, it can help us, make sure that they were in fact having true UTIs and differentiate them from just having dysuria with negative urine testing. And then the other thing is it's really helpful for us to see those sensitivities. So that if we're going to pick out a prophylaxis for them, that we're picking the right kind, that it's actually that all of their infections have been sensitive to that prophylaxis. And then the other thing is that if any imaging has been performed, having the patient bring the images on discs so we can sort of look at it with our own eyes is always really helpful as well. I put my contact information here so anyone knows how to reach me. I am in the long process of trying to change my name, so I put my new last name here as well to avoid any confusion. And then my pager number and our urology nursing line as well. But I'm happy to field any questions. At what age should we refer if the foreskin cannot be retracted at all? That's a great question. I have parents ask me this daily. The truth is that there's not a black and white answer that anyone has sort of like come to agree upon. And this can also vary a lot amongst providers as far as when they decide to treat. I would say that certainly if the patient is symptomatic at all, that we would recommend treating them. So if they're having ballooning of the urine, if they're having trouble getting the urine out, if they're having pain, then those are certainly reasons to come see us. I often mention to families that maybe if it's not really retracting well by like 5 or 6, it's always worthwhile to come in for a visit and we can sort of take a look and see how things, whether they would benefit from steroid ointment or not. There really isn't a black and white answer. It's really quite a gray area. Occasionally we have kids who present in the ER at 11 with urine retention from phimosis. And so ideally we're just catching them somewhere between, birth and that severe case. And there's not really a perfect age, but if you have concerns, we're always happy to see them. To me, it seems a little bit easier to treat them earlier with steroid ointment, which is very low risk, than waiting until the last minute until they're really having problems. What are the age and dosage guidelines for adult fiber gummies? So I just tell everybody to get the adult fiber gummies. It's just fiber. I think 2 fiber gummies generally has about 5 grams of fiber, which is really not, it's not going to like overwhelm them and push them into diarrhea. Usually if the kid is less than 45 pounds, then I have them just do like the 1 adult fiber gummy. And if they're over 45 pounds, then I have them do the 2. It's sort of along the same lines as like the maintenance for Miralax. If they're less than 45 pounds, we have them do half a capful. And if they're over 45, we have them do 1 capful. But the truth is that if they're on maintenance constipation therapy, they really can adjust that dose as needed to make sure that they're having 1 soft skinny poop every day, or 1 to 2 soft skinny poops every day. And if the patient's needing like 5 or 6 fiber gummies, they should probably just transition to something a little bit stronger. Working inpatient mates tend to have febrile UTI pilot patients. That's sort of like as far as whether the patient should be referred to us or the pediatrician, that's really at the pediatrician's discretion. If they feel pretty comfortable, like, managing, meaning that they think that the child needs a VCG and then they get the VCG, certainly we would want to see them to go over those results, because reflux is something that I think probably should be managed within the specialty. So yeah, actually I would say that pretty much anybody who's presenting with like a febrile UTI or pyelo should be referred to us. There are certainly exceptions. If you have like a 14-year-old girl present with pyelo and it's her first infection, then my suspicions for reflux are rather low. But again, we're always happy to see them erring on the safe side as well. I think that's all the questions.
Thank you so much, Ashley. We appreciate your time and your expertise, and to all of our speakers today, thank you so very much. We appreciate it. And thank you for everyone who joined us today for our conference. So as a reminder, this program is offering 5 free CME credits through the AAPA, and you should receive an email with an evaluation and instructions on how to claim your credits. So please don't forget to complete that survey. And then As we look to close, I just want to mention PSV does offer 19 specialties and counting. We are always growing and currently employs over 25 advanced practice providers in these specialty areas. And many of our providers have agreed to participate in our networking hour. So if you would like more information about the services that we provide, please feel free to visit our website at psvcare.org. And PSV providers, if you are available to kind of, be present and turn on cameras or at least list your name and specialty area in your Zoom window, so that providers may be able to easily identify us. If you have additional questions, please feel free to email our coordinator at psvevents@psvcare.org. Thank you so much for everybody coming today, and feel free to stay on as you're able to network with each other for the next 30 minutes or so. Thank you, guys. Does anybody have any questions?
Thank you, Ashley. That was really interesting talk.
It was.
I just want to say